Good afternoon and welcome to today's meeting of the Health and Wellbeing Board. My name is Councillor Ardencio and I'm the co-chair. Thank you for attending and welcome. The meeting today is open to the public and is being webcast. We have received 2 questions from a member of the public. The agenda and the reports for today's meeting are available on the council website, and a small amount of paper copies are available here at the front if anybody wants to grab one. Please can I request that the mobile telephones and other such equipment are switched to silent mode so as not to disturb the conduct of the meeting. There is no fire test planned for this afternoon, so if there is an emergency evacuation, please take instructions from members of the town hall staff, and the assembly point is to the square. I will now very quickly go around the room and ask people to introduce themselves in the inner circle here, and then people who are presenting reports will introduce themselves later, and I will start on my left.
Yes, Douglas Johnson, a councillor. I chair the Housing Committee.
I could just shout. Must be GP representing PCNs in Sheffield.
Greg Fell, Director of Public Health.
Catherine Roberts-Shaw, representing the Sheffield Health and Care Partnership.
Helen Sims, Chief Exec of Voluntary Action Sheffield.
Kate Martin, Exec Director, City Futures Portfolio, Sheffield City Council.
I'm David Black, Medical Director for Development at Sheffield Teaching Hospitals.
I'm Helen Steers from Voluntary Action Sheffield.
I'm Sarah Betty, representing Synergy Sheffield Mental Health Alliance.
I'm Dawn Dale, Councillor and Chair of Education, Children and Families Policy Committee.
I'm Yvonne Millard, Chief Nurse, Sheffield Children's.
I'm Megan Ory, Voluntary Sector Representative, and I work at SOAR Community.
Lindsay Butterfield, Sheffield District Commander with South Yorkshire Police.
Andrew McGinty, GP and Clinical Director at Sheffield Police in the ICB, deputising for Zach McMurray.
Judy Robinson, Chair of Sheffield Healthwatch.
Philippa Burdett, Democratic Services.
Thank you, everybody. I just have one thing to mention now, because of how full the timetable is. I am going to suggest that we have item 8 immediately after item 6 on the agenda, and then have the rest of the afternoon for the main meaty bit of the meeting, so that we can then conclude quickly at the end. Is that? I hope that is okay. Thank you. Apologies for our absence. We have quite a number. I have here Sandy Buchan, Ben Kemp, Dr. Zach McMurray, Joe Rennie, Dr. Tony Schwartz, Emma Latimer, Alexis Chappell, Meredith Teasdale, Rob Sykes, and Kate Joseph. So I've all sent their apologies. Are there any more apologies that I'm not aware of? Brilliant. Declaration of interest, item number 2. Are any members of the board needing to declare any interest in today's business? Thank you. And finally, item 3, I'm going to pass to the Director of Public Health. We received 2 questions from a member of the public. However, they are both unable to attend today, but Greg is very kindly going to read the questions and answer them for us.
Thanks, Chair. They're both long questions and long answers, so I'm going to try and paraphrase, but we'll publish the full question and the full answer. The first question is from Louise Wilcox, and thank you, Louise, and largely pertains to, are there potential plans to enable GPs to prescribe home repairs and other types of repairs to homes on prescription? Seems to be happening in other local authorities. What are the views in Sheffield? And ditto some questions about homeowners and the tenants whose mental health is impacted by antisocial behaviour, and that affects mental health, and obviously then demand for services further down the line. Thank you to officers, particularly in housing, that put together some answers, and I will do this properly and in full, and we'll publish it. But the sort of 5 key points with regard to Louise's question is one, Sheffield doesn't have any current plans relating to GPs prescribing home repairs. We're well aware of the government legislation on rights to repairs, but that is obviously separate from a GPs prescribing home repairs. Ditto with regard to tenure, the council and other social landlords are responsible for undertaking repairs to the properties that we or other social landlords own. Similarly, private landlords are responsible for undertaking repairs to homes that they own, and tenants are responsible for reporting repairs to the landlords and providing access so that work can be done. Well aware that we need to get that work done promptly. On the antisocial behaviour and community safety and then mental health point, the council and others work very closely with a whole range of partners to identify and address community safety issues, including but not limited to antisocial behaviour, and that they impact on mental health. In serious cases, landlords can take action to evict perpetrators. Obviously, we'd undertake that with a very heavy heart and as a very, very last resort. And the last point that's worth me making is that the council housing team are working closely with colleagues in health and other organisations to see what more we can do to increase the work between housing and health as 2 sectors, and there's lots of good work going on. There is a newly established South Yorkshire Health and Housing Group chaired by Janet Sharp, who's the Council's Director of Housing. That obviously feeds directly into that, and the right officers will follow up with Ms Wilcox and do a proper full written up answer. That's the first one. The second one, shorter question, so I will read it out, but a long answer. So again, I shall paraphrase the answer from Mrs Theresa Quincy. I'd like to put on the agenda for discussion at the next meeting the provision of psychology service for 16 to 18-year-olds in hospitals. This cohort of patients falls outside CAMHS and IAPT, and because of lack of provision in an adult hospital setting, transition can sometimes be held back. That causes strain on children's services and negatively impact on patients' well-being. So there are a few points to make in response. Again, it's a long answer, so I shall paraphrase, but we'll publish the full answer. There are 3 broad issues: psychological support for those aged 16 to 18 in any inpatient bed, whether that be teaching hospitals or the children's hospitals or elsewhere. Psychological support for 16 to 18-year-olds in specialised commissioning beds, and then transition care management. So in relation to the first point, patients in the teaching hospitals are covered by the mental health liaison team. That's a multidisciplinary team, provides access to consultant level psychological support. It's not a 24-hour service. And with regard to the Children's Hospital has a psychology service, PANDA, which covers activity generated in and from the Children's Hospital as an acute site. That's independent of age, but it's specialty based and covers 16 to 18-year-olds who remain under the care of the Children's Hospital. And the CAMHS inpatient standards has psychology and therapeutic support based on site in line with QNIC standards. With regard to the specialised commissioned inpatient services, each of the specialised commissioned inpatient services has psychologists as part of the multidisciplinary team component, and all health partners have recognised the inappropriateness of 16 to 18-year-old people that present in emergency departments and are detained under the Mental Health Act whilst waiting for Tier 4 beds to be identified. To mitigate against that, dedicated bed for this cohort for patients has been commissioned from January 22, and that's drastically reduced the waiting time for young people in A&E. Clearly that's good. And with regard to transition care, there's been a huge amount of work, particularly recently across Sheffield, to manage transitions between children's and adult services. That obviously includes mapping of activities of multiple teams across multiple specialties with the aim of learning from and then implementing best practice. And again, officers in the commissioning teams have offered to contact Mrs Quincy to do a full written answer hopefully colleagues at Children's Teaching Hospitals will say that and Mental Health Trust will hopefully not disagree with what I've said there. Hope so.
Thank you. Thank you very much. So we are on to item 4 on the agenda, which is the Healthwatch update, and I believe Judy is going to give us an update.
Thank you. Colleagues, if you're new to this meeting, this is an update that Healthwatch does from what we're hearing, what people have told us through telephone calls and emails and focus groups and a lot of engagement with people in Sheffield over the last couple of months. And I want to pick out 3 things today. The first one is a project on long COVID, which we're doing with our colleagues at Voluntary Action Sheffield, very much a joint project. Its primary focus is on people from a lower income background and from communities marginalised by race. And so far we've given small grants to community organisations for themselves to do some local research. And so far we've heard from 440 people, so a lot of people coming back to talk to us about the impact of long COVID on them. This research hasn't been finalised, but I'm giving you an early indication of the sorts of things that we're finding. And I'm afraid they're rather negative, but that's how it is. From those people in those sorts of communities, a difficulty in accessing GPs, but particularly around interpreters, and a feeling that their worries about long COVID are not quite being heard. And a lack of information in the right formats for people to understand what long COVID is, what the symptoms are, where to get help. And then I think quite concerningly is a lack of trust in the quality of care given to people from Black, Asian and other minoritised ethnic groups, and a hesitancy to seek official help. I think the idea that the NHS is loved by everybody isn't actually true across the piece, and the asylum seekers, some of the Roma community, find that approach and how they're received quite a difficult one. And I think those are indications of some of the things that we need to know about to do health inequality. Those are some of the challenges. That project is going on, there's more work to do, and we'll come back to you on further findings. And that's been done with the Sheffield Teaching Hospital, so we hope that will translate into changes in some of the practice that will help some of those people access the support that they need. That's one. The other 2 I picked out around mental health because that's the theme of today's meeting. When Healthwatch was looking at its priorities for the next 2 years, that question of mental health across the age range is one that came up as people's priorities, and we talked to a lot of people. And indeed, it is always a priority. This is not new. It's a repeated issue. And I just pick out 2 things. We've been hearing quite a bit about waiting times, but particularly about waiting times for recovery services. So you've had the main intervention, what happens next? Sometimes people have been allocated a worker, but that worker moves on. Sometimes they've been offered an appointment, but it doesn't happen. And they've sometimes gone back onto the bottom of a waiting list for quite significant periods of time. We know that there are workforce challenges. You know, we really get that. So these things are difficult. But there is a real challenge about communication. And people say, if we knew what was happening and understood it, we'd be less frustrated and worried about the service. So communication there as well as the recovery services. And then the third one I want to pick up, also related to mental health, is about all that work that's done without a capital H, saying health, all that work that's done in communities that support people to stay happy, healthy and well. Prevention, I suppose. We've heard from some communities how statutory services really don't meet their needs, and the voluntary sector is sometimes better at doing that. And they pick out things like understanding cultural and spiritual beliefs, faith issues that maybe don't get translated very well. And that rounded support of support for recreation, for physical spaces where people can meet. And I know in the voluntary sector, increasingly, the room in the church hall, the room in the community centre has to be bought. So those things that the knit and natter, the informal drop-in, all those things that don't, they haven't got a big MH in front of them, but they really help people. You spot that somebody hasn't come and somebody pops around. They tackle that issue of loneliness and isolation, and they're a real canary in the coal mine. If you're not doing that, you're probably getting people into crisis quicker. And we particularly hear that from minoritised communities, that their access to spaces to meet and that rounded support isn't often available. So I think there are some indicators there which I hope will inform the conversation that we have in the next hour or so. But these are things that people are saying now, and they're real to people in Sheffield. Thank you.
Thanks, Judy, for that. Are there any questions for Judy? Or can we move on to the next item? Okay, so next, thank you very much for that. It's really good information. So we're moving on to item 5, is the Better Care Fund update. So Martin is going to give us a very short kind of summary of it, and then I'll take questions, but I will curtail questions just to allow the main item on the agenda to happen in the times that has been allocated. Thank you.
Thank you, Chair, and good afternoon, everyone. I'm Martin Smith. I'm the Deputy Director of Planning and Joint Commissioning, a joint role between Sheffield Council and Sheffield ICB, and I lead on the development of the Better Care Fund plan that is owned by this board. It's a two-part report that just provides a summary of the 22-23 Better Care Fund that was submitted, and the 23-25 Better Care Fund plan that went in yesterday. Apologies that the report was only sent yesterday. We made the decision to send the final plan round instead of a draft. We did have an extraordinary briefing session on the 16th of June to update members around it, and all the comments were incorporated at that session. We submitted the draft plan on the 23rd of May and received comments back on the 20th of June, so that's why the timeline's really short effectively. So we were asked to make some changes to the plan between that, and the plan was signed off on the 26th of June by the chair and submitted yesterday for the timeline. I'm just going to sort of do a whistle stop of what's in there. In terms of the 22-23, we achieved all the national conditions in 3 out of the 4 metrics. So we achieved the reablement measure in terms of the 91 days from hospital. We had an 80% target and it was 85. We achieved the admissions into residential care target, which we had a plan of 710 as a rate, and it was 686. The area that we did find difficult, I would say, to set a target for was around unplanned admissions, and that's around long-term conditions as emergency admissions going into the hospital. And we think the long COVID impact has affected that. So we've set a measure this year looking at, so the target was, the measure was 10% higher than the target, so we weren't wildly out, but we've worked on that for the next year. And the proportion of people discharged home from hospital is still really good. It's one of the national best practice ones at around 98%, and we had a target of 97. So we did very well with the plan. Everything was delivered, and the discharge money has come. The additional discharge money they put in last year was encouraging to see that the data was moving, and we had good feedback on the schemes we invested in last year. What we would normally do is do a summary of what was good last year, but we've incorporated that into the 23-25 plan. There's case studies inside that, and because obviously members haven't had full time to digest it, if there's any questions following, we're happy to answer those, and if there's any questions for anybody who's read the papers or the plan, we're happy to take this back and respond to them outside of the meeting. The 23-25 plan, the guidance was published on the 4th of April, and as I said, draft went in May, feedback 20th of June, submission 28th, so it's quite a tight timeline. And it is a partnership, it has been a partnership plan. It's been fed in through, mental health, voluntary sector, the acute trust, and it's got loads of elements around unpaid carers, housing. It's quite a chunky plan to try and put together and do the alignment to what we want to achieve. The policy objectives remain the same as they have been for a number of years, which is one, enabling people to stay safe, well and independent at home. So put a description together of what's in our fund. The 23 fund is £493 million worth of health and care services. So we've kind of tried to describe how those teams are working on the ground, what we're doing to support people and individuals and communities. And then the second part of the fund is really about how we're supporting discharge, how we're getting it right, how we're just making sure that people are only using clinical services when they need them. The national conditions are the same, although they've moved those two objectives into national conditions now, just to strengthen them up. The metrics are the same as they were last year. They've added one new metric, which is around the falls in the 65 plus category. So we've set a target around, what that is and reducing the number of falls we're seeing. The narrative plan, again, had to have preventative services, community, housing, unpaid carers, what we're doing around equipment, disabled facilities grant. They're all conditions of and there's a set of key lines of inquiry to put in the plan. As I said, it's gone through a number of iterations and been through a number of partnership meetings, including Adult Social Care Leadership Team, Partnership Committee, and we've had lots of feedback that we've incorporated into it. We had to put in a demand and capacity plan as part of this year around intermediate care services and what services we can use to discharge people, link into a sort of a planning submission around where people can move and trying to support the discharge to assess and home first model. The Adult Social Care Discharge Fund is again in there. We did a partnership approach to decide what schemes would be funded this year. On the 13th of June, those were shared at the Health and Care Partnership Committee around, this is what we're doing, so it's all transparent and out there around what we think will make the biggest difference. There's fortnightly reporting on that and the impact it's making. There's monthly reporting on the capacity and demand, and there's quarterly reporting on the metrics, so there's more reporting heavy than it's ever been. As I said, the plan submitted yesterday is going for regional moderation. We should get the feedback 28th of next month. Then it's got a cross-regional collaboration in August, and we should get our final approval in September. And the Section 75 agreement that holds all the funds behind the Better Care Fund needs to be signed off and agreed by the 31st of October. But currently, we've met all the national deadlines and targets as a board. Thank you. I'm happy to take any questions.
Right. Any questions? Wow. Oh, direction.
Thanks, Martin. 3 quick points. One, thank you to you and the team, because I know it's a massive effort, because it is a massive effort, so thank you for doing it really clearly and coherently. You know what I'll say here. The narrative plan says the right thing. The metrics are all about discharge from hospital. That's not unimportant, but there's a bit of, and I clocked what you said about the sort of the more reporting heavy than it's ever been. There's a point that you get to the administrative burden of that. Does it add value? I know that's not your making. That's further up the chain. There's a bit of kind of the plan pushes the right way. We'll hit the target, but maybe miss the point in all of this. And again, you've heard me say that before, but I will keep saying it. And just, I'd clocked that in the pack, there was the place plan. I suppose particular thanks to Emma and team who did that. I sent a brief note to Emma this morning. It clearly doesn't capture everything that is NHS, but it focuses on some really important stuff in a really clear and coherent way, and I think the team that did that to be congratulated, because it provides a lot of clarity in a sea of difficult to manage confusion. So huge credit to the folk who did that.
Yes, and thank you from me as well. As the person that signs off the plan, I want to ask what we can do as a board to ensure that we align the timescale of when the board meets with the national kind of deadline, and maybe that's something that we need to put in the diary for next year, Dan. So time, because obviously the deadline was yesterday and we are meeting today, and that was something that we couldn't really help, because this is when the meeting was in the diary, but maybe if we look ahead to next year so that we can align them better, so people don't feel like we're rushing, and we could actually sign it in this meeting in public rather than having to have. So now we know that the end of October is when we get the final sign off. Next meeting is on the 28th of September. So can we just try to work in a work plan on how we get around that, if that is okay, so that it feels more transparent and we can have it in public. I would really like us to do that. And I know it's nothing to do with you. I know it's us as having to kind of think ahead and in terms of democratic services and getting meetings timetabled so that they align better with national deadlines. But thank you for all your work, because I know it's been quite a lot of kind of condensing lots of different comments from all the different partners. So it's been a huge piece of work. Thank you.
Yeah, and I'm happy to work on the timelines up to, and thank you.
That is, I've got item 6 now. Thank you, Martin. Refresh of the joint health and wellbeing strategy. Greg, is that you?
So I'll start, but very briefly I'll hand over to Susan, my erudite deputy. So we have to have a health and wellbeing strategy as a city. We currently have one. Obviously COVID knocked it a bit off course, now back on track. It runs out in 2024, so this paper is about largely the process of writing the next one. There'll be fairly light on content, but this is largely about the process. Hand over to Susan.
Thanks, Greg. Yeah, so for people who don't know me, I am Susan Hurd. I'm one of Greg's Assistant Directors of Public Health here in the Council. So as you know, the Health and Wellbeing Strategy runs out next year. So we've started the process for refreshing it. Myself and Chris Gibbons, who sat behind me, are leading it for Greg, with a small number of members of the board who are helping us on the editorial group. And the names of the people who are involved are in the paper, so you can see who they are. I would say if anybody's keen to join us, you'd be very welcome. And the plan is to build on the last strategy, which obviously had a lot of engagement, a lot of work put into it, and is very good. And there's a lot of engagement work that's happened in the city. Healthwatch work from 2018 is still hugely relevant for the last strategy, and the ICP and others have done an awful lot of engagement work over the last year or so, and obviously the city goals engagement work's happening at the moment. So the plan is to draw on all of that work rather than repeat some questions that might be getting asked of the public at the moment, to pull in as part of the evidence alongside other things that we'll draw on, like the joint strategic needs assessment, etc. Because of the close link with the city goals work, you'll see in the editorial group we've got involvement from Di Buckley and Jen Rickard, who are heavily involved in the city goals work because it's so related and relevant to the health and wellbeing strategy. Which leads me a bit onto timescales. Timescales are challenging. Ideally, we'll have this done by March next year, but it is somewhat contingent on the draft city goals being published, hopefully early September. So things do get a little bit tight. I've put in the paper that ideally it will be March, but it may slip till after the May election, so that would be June next year by the time we've published the refreshed health and wellbeing strategy. In terms of process, like I said, we've got a desktop review going on now with the editorial group, and you'll see in the paper in section 5, we're planning to have a conference for the board in autumn for yourselves all to have significant input into the content. We're timing it hopefully so that the city goals will be, at least draft city goals will be published by then. And then there will be a furious period of writing content and talking to you all over autumn into winter. There'll be a second touch point with the board, hopefully December, January, in terms of how the content's shaping up. And that's where we're at with the process and what we're doing so far. And I guess my questions for you really are, is there anything from having read the paper that you think is missing from the process, that you think should be in there? And also, it'd be really helpful to get your steer on the role of other organisations in terms of development, but also endorsement of the strategy. Thank you, Chair.
Brilliant. Are there any questions? Very good. Thank you. Okay.
Sorry.
David.
So I just wanted, David Black from the teaching hospitals. You asked about the process, and I think that in the trust, and I'm sure the other trusts, we're really anxious to do our bit our whole purpose is to lengthen people's lives and improve the quality of their lives, which has to be closely aligned to a health and wellbeing strategy. And we're anxious to also do so in a way that reduces inequalities. So I think my question is, and maybe a suggestion, is that you have within your function a healthcare public health function. It would be, I think we'd find it very helpful at the trust to have a workshop for us to talk about what could we do around the way we deliver services that would help to improve outcomes and reduce inequalities. And I know that the public have said they want more preventative healthcare. We do try, but also better access to healthcare services, which is our bread and butter. And we provide services to people with mental illness, learning disability, autism, homeless people, travellers, people whose English is not their first language, and specialist services to particularly vulnerable and disadvantaged groups like people with hemoglobinopathies and sickle cell disease and so on. And I think we struggle sometimes to know how we should do that in the best way to ensure equitable and proportionate access in the way that Marmot talks about proportionality. So I think if you were to offer us something, we'd really appreciate that, because we're refreshing our clinical blueprint, and perhaps we could do it with the other two main trusts, because we all have a lot of interfaces in what we do. So it's kind of an offer and a suggestion to really make sure that we know we have to do stop smoking, we do that. We know we have to deal with alcohol, we've got an alcohol treatment team, we do that sort of stuff. This is more about how we deliver our services in any particular population groups that whose needs we're not meeting properly.
I think, yes, and it would be interesting to hear what Greg wants to say about this as well. I think that for me there's the two things, there's the what and the how, isn't there? So there's the what, the content of the strategy, and then the how, the delivery of the strategy, and I can see what your suggestion fitting both of those actually. So something we'll take away and chat about and consider and think about how we do that. But like you say, not just with STH, but with other trusts as well, or other organisations that are interested.
Greg?
Cheers, David. Yeah, just to add, yes, in short, probably with the sector rather than organisation by organisation, that's just the practicalities of organising multiple stuff. And well aware that there's amazing stuff goes on day in, day out across all bits of the NHS. For me, the job is better, positive trajectory, etc. And just to repeat Susan's ask, if anyone wants to join the editorial group, you then get to help shape the content and the house as well. So open offer to anybody.
Okay.
Thank you. A similar sort of question, but I'm just wondering, it mentions about the critical importance of communities in the creation of wellbeing. So at what point do communities engage with this? Is it in the drafting of the actual strategy? And how, I suppose? I know you've got some ideas there about this board being involved in a workshop, and it says plus a small number of other people. Who are they, and how do we engage more wider communities, and particularly diverse communities?
Thanks. Yes, it's tricky, and I may come to you for some suggestions and some ideas. We have talked about this in the editorial group around trying not to duplicate work that's already gone on. So, we don't want to irritate people by asking them the same questions again. They've already been asked. But, and obviously the City Goals work's ongoing at the moment, but being able to have a look at that come autumn time and say what's missing, what do we really want to add to in terms of what we need to ask people, and then how we do that is a question beyond what I've actually thought about yet. So I'd be really open to ideas and suggestions, and I think we're all in the editorial group really conscious of not wanting to miss that, but also not wanting things to be tokenistic again. So I think, I imagine that it may well be quite a significant topic of conversation at the board event in September, but really open to conversations before and after that as well around it, so we get it as right as we can.
I have Greg and then Helen.
Very, very briefly to add, the hot day in St Mary's a few weeks ago where the microphones didn't work, there's a direct line between what Susan's describing and that day, and the content. We haven't worked out what the content of that day will eventually kind of get written up like, but that was part of the helping build and shape both the what and the how.
I was also going to add that I'm going to give you an offer. I'm offering to join the board to look at this because I've been leading the collaborative conversations work, which is part of City Goals, and therefore working with 20 very diverse community organisations to have sort of deeper conversations in communities. So I think there's a lot of content there, but what's also coming out of those conversations is some of the how. So I think I could perhaps bring that into that space. So.
Thank you, and thank you for the report. Brilliant. So I'm going to bring forward item 8, which is on page 35 of the printed report. Those are the minutes from last meeting that happened on the 30th of March. I'm going to ask whether anybody disagrees that this is an accurate record of the minutes. People in it are happy with them. And are there any matter arising from the minutes that people want to bring up? Brilliant. So can Greg?
Just very briefly, so that board members know, we had a long conversation about the food strategy, and the recommendation was that get taken to Council Strategy and Resources Committee. I think it's scheduled for early July. Soon, very soon anyway.
Brilliant. Excellent. So can we agree that those are the minutes? Yeah. Fantastic. And I am going to just very briefly introduce item 7, mental health and wellbeing in-depth review. I am going to hand over to Heather Burns and Josie Sota, who are going to chair and lead on the rest of the afternoon. We are aiming to finish no later than 5. It's a very tight timetable. And I just want to say that this is just a marker in the sand. It's not us ticking a box. It's us starting a conversation and starting a process and addressing the issue of parity of esteem of mental health and physical health, and the impact of mental health on physical health. We're going to listen to lots of different experiences and listen to lots of different people. There is a break-stroke exhibition thing where we physically have to move next door, which is quite challenging because we only have 15 minutes to do that. But I am going to remind people about time, so I'm going to set timers on my phone to keep people on track. So I'm going to be the bad cop today. Okay, thank you.
Thank you, and good afternoon, everybody. I'm Heather Burns. I'm Deputy Director of the Mental Health, Learning Disability, Autism and Dementia team at South Yorkshire ICB, Integrated Care Board, at Sheffield Place.
I'm Josie Suter. I'm the Managing Director at Sheffield Flourish, and we've just come along to really help with the facilitation and done some of the videos.
So thank you. And around me I also have a number of colleagues from some of the health, social care and voluntary sector organisations, and they will be forming the panel later. So I'll get them to introduce themselves as we just start the process. Jeff, I think you're on the back row at the moment, but there is a seat here for you, but thank you. So I'll just start over here with Reg and Sarah.
So I'm Sarah Batty. I work for Rethink Mental Illness, but here on behalf of Synergy, the Mental Health VCSE Alliance.
I'm Helen Steers again. So I'm the Director of Strategic Partnerships in Voluntary Action Sheffield, and I work with the Mental Health Long Acronym Board.
Thank you.
Good afternoon, I'm Mike Hunter. I'm Medical Director and Deputy Chief Executive at Sheffield Health and Social Care, and I'm a consultant psychiatrist when I'm being a doctor.
And I'm Nikki Doherty. I'm Deputy Chief Executive and Director of Business Development, Partnerships and Strategy for Primary Care Sheffield.
And apologies, colleagues, I now need to bring in my colleagues on the back row who I didn't quite get steered into a seat in time. So, Tim.
Hello, I'm Tim Gollings. I'm Assistant Director for Adult Social Care, dealing with mental health, safeguarding and access. And actually standing in for Alexis Chapel, who's the Director of Adult Social Care.
Thank you. And then Teaching Hospital.
Good afternoon, I'm Mark Cobb. I'm the Clinical Director at Sheffield Teaching Hospitals and part of our mental health team. I'm here with my colleague.
Good afternoon, I'm Carmen. I'm the Mental Health Lead for Sheffield Teaching Hospitals.
Sorry, Jeff Perring, Medical Director at Sheffield Children's.
And I have another colleague behind me.
Oh. Hello, I'm Margaret Lewis. I'm the Chief Exec at Sheffield Mind.
So thank you. So the way that we've planned this session is to take you through some challenges in the city, some opportunities as well, but also we're going to be starting the conversation on behalf of people with lived experience of mental health condition, and we're doing that in two ways, through a series of videos but also the art exhibition. So when we get to that point, I may need to split you into two. But overall, the session's outcomes are for us to provide an overview of the current state of mental health services and mental health and wellbeing within the population in Sheffield, to discuss the key challenges and barriers that we face in improving mental health services and mental health and wellbeing, to look at exploring strategies and solutions, and particularly, Greg, you asked us to challenge the Health and Wellbeing Board around that, because it is what we're all doing in partnership that makes a difference to this agenda. And also to facilitate that networking and collaboration to develop those joint working approaches across all ages. Now, we've sent you an information pack, which we didn't expect you to have the opportunity to read beforehand, but why we've provided you with that resource pack is so that you've got something you can consistently go back to and continually revisit, which will give you a whole range of information about the strategies, about some of the population stats and infographics that we've prepared, Flourish have prepared on our behalf. And we would like you to kind of utilise that afterwards to really help to embed some of the facts that we're trying to convey today. So by the end of the board, we're hoping that you'll have an increased knowledge of the challenges, that you'll have some of that more up-to-date, meaningful information to understand what meaningful changes we need to drive, and to help us to identify key priorities. And as I said, today is all about you as an individual as well as a board being challenged. And what we're going to do is hear from the voices of experts, as we've said, but also the voices from our key partners in the city around their challenges as sovereign organisations, but working within the Mental Health Learning Disability Autism Delivery Group, and Dementia Delivery Group. So it's us as partners, but also giving you a kind of a subtle nuance from each organisation around their own challenges. So with that challenge in mind, I'd like to introduce, in true Eurovision style, Steve Thomas, who couldn't be with us today, but has prepared a video, and you could get your scorecards out for the end, perhaps, in Euro style.
Three Sheffield people. Farah comes frequently to her GP with chest pains, gastric symptoms, constant fatigue, nightmares, insomnia. She's been seen multiple times in hospital. She had a job on arriving from Iran after escaping a life of abuse, but she can no longer work. She's plagued with the guilt of having fled her country and having left her children behind. She's on a 2-year waiting list for psychotherapy. John can't understand why his diabetes is so poorly controlled. He's gaining weight, he struggles with smoking and alcohol use, and the voices that he's lived with for most of his adult life are by and large stable, but occasionally troublesome. But at 45, he's given up hope of ever having a job. His living conditions are poor, he struggles with finances. Jake, at 15, is intelligent and should do well in the exam system, but over the last 18 months, low mood and overwhelming anxiety have paralysed him and his family. He often feels that he might be better off not being alive. Our agreed strategic intent is that mental and emotional health and well-being are at the heart of all that we do as a city and is valued the same as physical health. There have been improvements over the last decade or so, sort of with destigmatisation of mental illness and some increased resources, but these narratives illustrate a snapshot of what continues to happen in Sheffield. Many of you will know the headline statistics of 1 in 4 of us experiencing a mental health issue at some point in our lives. But what does this mean for Sheffield? Well, it means that 90,000 people experience depression and anxiety, but only half of those are ever recognised and only half of those ever treated. 16,000 people live with the consequences of lifelong complex trauma, 5,000 with severe and enduring mental illness, and 50% of all lifelong mental illness has established itself by the time a young person is aged 14. Up to 50% of all of our acute hospital outpatient activity, particularly within gastroenterology and cardiology, have no organic cause. Loneliness is as big a killer as smoking, and suicide is the leading cause for death of men under the age of 50. 5 times as many black people are diagnosed with schizophrenia compared to white, and are more likely to access their mental health care via accident and emergency or the criminal justice system. The economic and social costs of mental non-wellbeing are huge, amounting to over £1 billion for Sheffield on an annual basis. Take a peek at your resource pack. There is little parity with physical health waiting times, and long waits to intervention are less effective than if they were delivered in a more timely way. We fail to address intergenerational cycles of illness, adversity and inequalities in childhood, and the wider determinants of health and well-being are of fundamental importance, including tackling poverty, poor housing and education and employment opportunities. Today is about recognising the importance of the promotion of wellness and that of health creation, and seeing mental health and well-being on a par with physical health. Today is about revealing the scale of the problem, illustrating the impacts on people, which includes, of course, death and illness and disability, and of course to develop solutions and commitments. There is an urgency to action needed related to funding and resource allocation, workforce development, the integration of physical and mental health care, and empowering the work of community partnerships. Dare we shift resources? Dare we disproportionately invest to the benefit of our population? There is a strong economic case. This is everybody's business, and this board has a responsibility and accountability to direct those resources. So again, I ask, is mental and emotional health and well-being at the heart of all we do as a city? Is good mental and emotional health and well-being for all at every stage of life our priority?
Sorry, thank you. It's not often I get a guitar fanfare when I start speaking, but I quite enjoyed that. So Steve was setting us that challenge around the population needs within the city, our responsibilities as the Health and Wellbeing Board. And what we're going to move on to later, when Chris Gibbons steps forward to talk about some of the statistics, is get underneath that a little bit more. But in terms of our next part of this session, we wanted an opportunity to showcase some of the positives that have been happening across the city, particularly over the last 12 months. So we're going to see what's called the video montage section, which is the 20-second challenge, and Steve even had a 20-second challenge as well, for a number of services to just describe to us what we're doing, because we felt it was a useful context for the Health and Wellbeing Board.
PCMH is the biggest mental health transformation that Sheffield has ever seen. It's a partnership of SHSC, PCS, Sheffield Mind, VCSE organisations and primary care networks. By early 2024, 8,000 contacts per annum will be seen within local communities. The new model is proven to address inequalities over access and address wider determinants of health. So Sheffield is leading the way nationally for mental health transformation.
Hi and welcome to Sheffield Support Hub. We're an out-of-hours support service and we open Monday to Friday 6 p.m. till midnight, Saturday, Sunday 2 p.m. till midnight. We're a non-clinical safe space where people can come relax, socialise, do arts and crafts, play games and have one-to-one emotional support if needed. We hope to see you soon.
Hi, Roundabout Safe Space offers up to 72 hours of care for young people aged 16-17 in mental health crisis. We provide 2-to-1 round-the-clock support in a calm, therapeutic environment, enabling de-escalation from distress, offering coping strategies and ensuring ongoing support.
Sheffield Mental Health Guide is a website that is run by Sheffield Flourish. It's been co-produced with our community and it has just over 300 different mental health services and activities on there. It's currently being developed into an all-age guide. We focus on making it more accessible for children and younger people. We will launch the revamp of the website in September 2023.
Mental health support teams are part of the government initiative to increase access to psychological therapies for children and young people in and around their schools. This gives a fantastic opportunity to reach all children and young people in Sheffield and maximise and build on the relationships that they have with school staff. The service currently works with a third of schools in the city.
People with a severe mental illness are at risk of dying up to 25 years earlier than the general population. They are eligible for an annual physical health check, which can be an effective way to identify and manage physical health problems. In Sheffield, organisations are working together to increase uptake of these checks, and in the last year alone, 1,300 more people have had their annual health check.
Hello. My name's Joanna Rutter and I'm a Health Improvement Principal at Sheffield City Council's Public Health Team and I lead the City Suicide Prevention Plan. At the moment we're focusing on rolling out our Talking Saves Lives campaign across the city and further development of our suicide support and prevention website. We're also increasing suicide prevention activity in communities for high-risk groups through our small grant scheme and providing increased support for people bereaved by suicide via our Amparo service and local SOBS group.
The increase in peak sort of presentations has been accompanied by some positive changes in the system, including increased staffing capacity, improved access to skills and training and upskilling for staff, closer working relationships between partner agencies, increased focus on prevention and intervention, and increased input from experts by experience.
I'm Helen Steers from VAS. The key mental health support provided by the VCSE in Sheffield is really strengthened by collaborative action. This includes VAS support for new models of working like the Mental Health Waiting List project led by SACMA and others. Mind with VCSE partners coordinate the Mental Health Partnership Network, enabling peer support and a collective voice for 50 organisations, and the Synergy Mental Health Alliance connects lived experience in over 100 VCSE organisations with strategic investment and decision making.
We are the Sheffield Senior Navigators, working with young people under the age of 25 with a diagnosis of autism and/or a learning disability.
Primarily, we work to avoid mental health hospital admissions and support the young people that are already in hospital.
We work across the systems to ensure young people's voices are heard, reasonable adjustments are made, and family stress is reduced.
I wasn't privileged to see the outtakes from everybody's filming, but I did see the outtakes from the last group, and they really should be shared because they were hilarious. But we're now going to go on to just talk a little bit about how does this all link to our key 4 strategic priorities in the mental health and wellbeing strategy. So first of all, addressing the wider determinants of health. Here's where I should have changed my glasses. Apologies, colleagues. Thank you. So the links to the joint health and wellbeing strategy and the theme around living well and ageing well. It also links to the adult social care strategy, theme safe and well, and also links to the ICB mental health and employment work stream. So those wider determinants of health, and we're going to be talking a little bit more about that later, around how poverty, lack of employment, lack of educational opportunities is actually helping to drive some of the mental ill health in our city. The second key strategic priorities in the mental health and wellbeing strategy is supporting the emotional and mental health and wellbeing of all our children and young people. And again, there are those links to the other strategies that I've just mentioned, but particularly around starting well and living well. We are going to be looking at a redesign of our children's mental health services over the coming year around how we might put more into early intervention and prevention. And then linked to that providing earlier help to people who need it. We heard earlier from some of the comments that you made earlier from the FAS report that we know that people need to access help in different ways, and it's not always through the statutory services, and that kind of earlier help is often the voluntary sector's best place to be in that position. And then the fourth key strategic priority is to provide effective and quality care and treatment services, and we'll be hearing from our partners across the health and social care provider landscape later. But that is around addressing some of the issues that you've talked to around waiting lists too. Okay. So in terms of our priorities from the health and wellbeing, from the mental health, learning disability, autism and dementia delivery group, we have 8 objectives that we had already identified as a delivery group, which covers tackling issues around access and flow and waiting lists, transforming adult mental health services, that's community mental health services and primary care services that we hear about later, recommissioning some of the learning disability, community and inpatient services, recommissioning some of the substance misuse services that we've got in the city, trying to design an integrated and holistic approach to the needs of children and young people, and then also delivering on the commitments of the autism strategy as one of our key objectives. And similarly, the key objectives within the dementia strategy. And dementia can often be overlooked within some of the wider priorities, and we've managed to get that on the agenda, of the South Yorkshire Integrated Care Board too. So we also want to continue and grow and develop the VCSE sector, and we want to work together to address those health inequalities. Some of the objectives of the healthcare partnership are around crisis care, and so we have another objective that kind of links to some of our delivery board objectives, and also a focus on autism waiting times. So we'll be developing our strategies and our work plans for all those objectives coming up. So I'm now going to hand over to Josie just to introduce the voices of people with mental health conditions in the city. And what we try to do is get quite a wide variety of people, and they've got their stories to tell.
So the first one we're going to hear from is a young guy called Jaden. So yeah, just play it.
Hello, my name is Jaden. I'm 11 years old and I live with my foster mum and dad, me and Blair, and my brother and sister. Mental health is just the feelings inside you. These can be good and bad. I know about mental health because I know people who have suffered with poor mental health. So the best way to help people with mental health is to find somebody who knows a lot about mental health and is qualified to talk to people about this, and get them to help the person who suffers with poor mental health. So I think that we can just like ask them. Don't bully them just because of the mental health, and also we can help them by asking them if they're alright. If something goes wrong, we can tell somebody else, like we can tell the professional. Yeah. I think we would all be very happy people if in Sheffield there were more parks, more foundation centres, more play areas, more football stadiums maybe, and more things to get you active maybe, because then that stops poor mental health and it can lead you to a good life. I use lyrics and raps to help me with mental health. I think this helps me a lot. Here's one of my raps. Thanks a lot for the joy and spirit. I'm a lucky little boy, but I won't push the limit. I'm 11 years old and I'm still the best in it. When adults talk to me, it'd be great if they comforted me. They asked what bothers me in the world and if I'm okay.
So breathing around the clock, I'm feeling the vibe incredible. Hey yo, J2W!
Thanks. Could you just pause it there a sec? So the next person we're going to hear from is, again, a young rapper called Kid Blue, who's going to talk about experiences of homelessness. I must apologise, there is a swear word that's gone in, so sorry I didn't catch it before, but hopefully you'll hear about her life.
Hi, my name's Kid Blue. I'm a female rapper from Sheffield, and this is a bit about me and a bit about my mental health background, since not a lot of people know about it. So when I was 14, I was kicked out, I was homeless, I was living with my friends, living on the street. I was also living in crack houses as well, like sofa surfing, because I had nowhere to sleep. And that's where we used to squat. So I suffer with hearing voices, and I also suffer with periods of blacking out and not remembering what I'm doing and zoning out and stuff like that. So for me, when I was about 16, just turned 16, I was put in a hostel with people that had just come out of prison, prostitutes, addicts, alcoholism heavily. I was also put in there with mums and babies, which was really upsetting. And I was also always getting my stuff robbed and stuff like that. The certain incident I'm going to talk about today, trigger warning, so I'm just going to put that out there if you get triggered easily. So when I was 16, I had a little tits up and I wanted to commit suicide. And the police came into my room and they restrained me from head to toe because I wouldn't go into the ambulance at the start, but I said to him, if you let go of me, I'll walk into it. And then they said that they had to restrain me, so I was bruised head to toe, I was dragged down 2 flights of stairs, and when I got to the hospital, they said that I'd done it and I had to be restrained and stuff like that. I had concussion, I've been concussed by them from whacking my head on the back of the stairs as well. What I feel like this city needs is people that are caring, that love their job, that they're doing, because when you're working with people with mental health, we can tell if you don't like your job. We're very in-tuned people, like everybody's got mental health, but people that have it severely and worse than others, we can tell instantly. I feel like the workers in the work environment as well should be highlighted, because the work environment, if it's crap, then you're going to treat your patients like crap. You're actually enjoying your job. Because then we can tell that you're actually in it more. And just listening is the main thing with mental health. If you sit there and you just blank face and you're actually listening to somebody, that could cure them for about a good 2 days, a good day, because they've let everything out.
When I'm living in a better place, stargazing, taking all this pain away.
It should be better to have a positive city in Sheffield. So if you want to follow me on Instagram, I talk a lot about my mental health through my tracks, and just so it can get across to people and stuff like that. It's at kid_BLU3E. And I have music on Spotify, YouTube, all streaming platforms if you'd like to get there. Shout out to Flourish. Thank you very much for having me.
Thanks. So the next one is a young lady called Naomi who identifies as LGBTQ and came to Sheffield as a student and has stayed on.
Hi, I'm Naomi. I'm a bisexual woman living in Sheffield for the last 8 years or so now. When it comes to mental health, I think that there's a lot of stigma around it, and frankly, there's not enough space to just be open and talk about the things that are affecting us. We all have mental health difficulties in one way or another, and I think that there needs to be a more person-centred approach in resolving these things, because oftentimes when you seek help, like if you want to get onto IAPT for example, then you have to fill out a survey. It's very methodical, and I understand why these methods are in place, but at the same time, the approach to mental health, in my opinion, is far more quantitative than it is qualitative, and we need to get into how people are feeling and like the whys of how these situations come around, because just, a measure of 1 to 10 on how bad they've been feeling on the last 2 weeks, while that is useful information, it is not helpful information to the person providing it. So, yeah, I feel like a much more qualitative method of mental health support is needed in our city. More personally speaking, I suppose having to kind of like live a bit of a lie and like not be 100% myself when you enter certain places, like, you know, tone yourself down a bit because you're going into work now, or, you know, look a bit like this because you're going to do a mortgage application at the bank now. All of these things where you have to segment and section off parts of yourself so you can be the most appropriate form of yourself for a particular purpose. All these things cause us to divide ourselves, and I think that is damaging for anyone's mental health. So yeah, I would like to live in a society where we can all be our truest, like 100% open selves without needing to segment or divide or hide anything. And yeah, I think people, me especially, would feel a lot better for it.
The next one, so we've got two left. The next one is a guy called Neil. He's been living with a disability for quite a long time now. So.
My name's Neil Simpson. I have lived in Sheffield for around 40 years. My mental health city would be a city where everybody was understood. You need to be understood, you need to learn how to listen. You need to treat people the way they want to be treated. I need to be treated the way I want to be treated. My experience of mental health disorder comes in the form of isolation. I have been isolated. I have experienced ever since I was a child the fact that I didn't get invited to things. It's also about the idea of defeating the nemesis we're facing now, which is the outbreak of loneliness and social isolation. The idea that you don't have anywhere to go. I have no one to see, I have no one to see. That's why groups like CAST and the various others are so important. They are part of that. There is an epidemic of loneliness, of isolation, an epidemic of people who have no friends. It's very hard for men to admit what their vulnerability is, because men don't. It's a tradition, big boys don't cry. It's the idea that because I walk funny, that I'm stupid. I have I've had arguments with people who try to help me, and I say it's very kind of you, but your attitude is patronising. I don't like it. I'm not a child, I'm not an idiot, because sometimes I feel maybe I'm not going to get listened to this. Maybe I go on too much. Maybe I do this. Me to find a place where I can feel well about myself.
And then this final one is an older gentleman called Mr. Salim. We tried to get him to talk a little bit about mental health, but he's actually very positive about the city. So we also got one of his workers to talk a little bit about the work they've been doing.
I came in this country December 1960. I started job, so I come to Sheffield where my cousin who used to live, first cousin. Right. Then ever since, I like Sheffield so much, and I love this country more than my own country. We got everything.
So one of ShipShip's aims has been to tackle health and inequalities across our neighbourhood. And we very much do that by working with communities of all ages.
As I said, if you have good education, different. Like my elder brother, my real brother, he was country's famous scholar, writer, professor. My hobby is every day, even this morning, writing. If somebody asks me something, I don't say, I don't know. Love reading. Well, local library, for 40 years, all staff, lot of retired now, they all used to know me very good. I said, we get everything, what we don't have in back home.
And one of the key things that always seems to be shared by people within the community is having an environment, having a city where it's inclusive and a meaningful city that shares people's views, people's difficulties, and individuals who have struggled and have got a lot of lived experiences, how we bring that to the table to make the city a mental health friendly city.
So thank you. We wanted to give people that opportunity to tell us their experiences and their life stories and their views of what Sheffield could be like that would make it more inclusive for them. And I think we've heard some themes around activity and connection, around reducing loneliness, around connecting with staff who care, who demonstrate that they care and who aren't potentially burnt out from the work that they're doing. We've also heard about reducing stigma. We feel we've done a lot around that, but people's experiences aren't telling us that. And we also wanted to sort of showcase that people talking about that person-centred approach, individuals having a response to their individual need. And also there was the link to physical activity, and the young boy at the start sort of saying, you know, more access to physical activity. It was a Health and Wellbeing Board's dream, actually, wasn't it, to hear that connection made. So with those stories in mind, we're going to move into the refreshment break, and we have got some art displayed next door. And what we want you to do is to really spend some time looking at the art and the narrative behind it, and just making a personal connection with some of the things that you'll see and read. We're slightly ahead of time, Chair, which is really good, isn't it? And what I would suggest, therefore, so that we're not all kind of rushing into one space and then rushing back, is perhaps if half of the board from this side forward go to look at the art exhibition, and then this side of the room you go and get your drink, and then swap over. I think that will probably work better. And we have Margaret from Mind, who's going to sort of potentially guide you around, because it was their art exhibition that led to us asking them to bring it today. So thank you, but your reflections are the really important thing, because we'll be asking you about that later. And after the break, we'll be coming into our presentations by our providers and partners, talking about the local challenges. So thank you. And that things like this have run to time. Let's see, it might all go wrong. So the next part of our session today is getting perspectives from some of the providers in the city, but also from a public health perspective on the statistics that lie behind some of those stories that we were hearing about earlier. So with great pleasure, I introduce Dr. Chris Gibbons, who's going to kick us off for the first part of this next session.
Thanks very much, Heather. Steve did a really good job of highlighting some of the statistics so that I don't have to, and that gives me a little bit more time to cover this in about 7 minutes. I will really do my best to stick to time. We all know the importance, and people have already spoken about the interactions between physical health and mental health, and that's quite well documented in national evidence, having both a significant financial burden on the health service and also a significant burden of quality of life on people and communities. But I would say from a data point of view that we are a little bit behind in terms of being able to link up the data that we have on physical health problems with those mental health issues, and create that sort of true person-centred view through the data is not very easy at the moment with the kind of data structures that we have, and it remains something of a blind spot. But we do know that mental health is a significant determinant of disability in Sheffield. About 1 in 5 years lived in disability for the population is due to mental health, and if you look at particularly children and young people, it goes down to about it goes up to about 1 in 4. So a significant burden of illness comparable with other physical conditions such as musculoskeletal problems. But really the key issue in Sheffield is the inequalities in the prevalence of those sorts of conditions. So the most common mental health conditions and the most severe mental health conditions are disproportionately distributed in the population to more deprived areas of the city. And not only that, but also there's data that suggests that the ability of people to live with long-term physical and mental health conditions is skewed towards the more affluent areas of the city, which is not, it's as tempting as it is to think about kind of individual responsibility and personal ability to make choices, etc. This is more about access to healthcare, inequalities, socio-economic and commercial determinants of health, and how they interact with these patterns of disease. In terms of time trends, things have been getting worse, and notably since about 2015, in all the kind of major population surveys, there is a significant uptick in both adults and children in terms of the most common mental health conditions, notably anxiety and depression, and that scales with deprivation. Similar trends have been emerged over those sorts of time periods around life expectancy and healthy life expectancy in the population, with a kind of turn in the curve around 2015. There's a lot of reasons that have been postulated for why this is the case. Austerity and cuts to services, certainly significant cuts to services like CAMS over that sort of time period. But again, this is about longer term gaps in inequality that have been entrenched since the 1980s and only got wider since then. And I also think that there's significant, alongside those cuts, the decision to allocate resources within areas like healthcare, for example, more and more towards acute hospital care provision and less so towards primary care preventative services. The opportunity cost of all that additional medicine that we've purchased in things like the Cancer Drugs Fund, etc., is health. Those trends are evident in data around children and young people as well. It's not just adults. And again, for anxiety and depression in particular, significant uptick since about 2015. Again, tendency for some think tanks to blame this on individual factors like social media use and mobile phone use, etc., amongst young people. It's much more to do with larger structural issues, particularly around, during that time, rising prevalence of adverse childhood experiences in particular. And again, those experiences being focused on the most vulnerable, the poorest in society. It's an intergenerational problem that's been entrenched for some time. This is data from our successful families in Sheffield. So this is a sample of about 2,500 households and families. 1 in 3 of those households in that group experiencing issues which could, things like domestic violence of parents and children, issues that will relate strongly to things like trauma and complex mental health outcomes. Those are distributed much more towards the more deprived areas of the city than they are the more affluent suburbs. Again, it's a structural issue. The other issue that you'll often hear me talking about in presentations is multimorbidity. And mental health is a significant component of multimorbidity. You can see the chart on the left-hand side there. Pick any condition you like: cancer, COPD, coronary heart disease. The most common multimorbid associations are pain, anxiety, and depression. We have rising multimorbid populations in the city, again, skewed towards ageing and poorer population demographics. The key statistic being a 10 to 15 year difference in onset of multimorbidity across that spectrum of deprivation, and at any given age, a 15% difference in prevalence of multimorbidity. Mental health conditions will be a significant part of that multimorbid epidemiology. Notably, there is a dose-response relationship between increasing physical health conditions. So the more multimorbid you are in terms of your physical health, the more likely you are to experience poorer mental health outcomes in a kind of dose-response way. So 2 or more long-term conditions, 2 to 3 times more likely, 3 or 4 long-term conditions, getting up towards 5 times more likely to have a significant mental health problem. And notably, the most significant correlation between physical health and mental health is in people who have poor respiratory health. And we know from data that we've got on inequalities locally that particular demand pressures in non-elective care come from people who have respiratory problems, and respiratory health in the city is very much concentrated, poor respiratory health is very much concentrated in the poorer eastern suburbs. Lastly, I just want to talk briefly about suicide. This is an area where we do have very good data. We have a real-time suicide surveillance system. My colleague Joanna Rutter has been responsible for some very good work in this space. That is combining quantitative and qualitative narrative data to have a proper intelligence-led suicide prevention program where we can leverage data, and that has meant that over the last few years suicide rates in Sheffield have not changed as they have in other places, been static around 50 per year. The other thing is that given that I've talked about multimorbidity and health inequalities, it's worth considering the question around allocative efficiency. Where do we spend the money to meet these challenges? And the best place for multimorbidity and complex patients with mental and physical health problems to be addressed is, one, upstream prevention, but two, in primary care. We don't currently invest anywhere near the same amount of money in primary care and preventative community services as we do in acute sector provision. So just to summarise, the prevalence of the most common mental health conditions is rising. It's associated with multimorbidity, complexity, physical and mental health conditions combined. We've got significant inequalities in the data. The allocative spend on health is skewed towards the acute sector, and trends in mental health were worsening prior to the pandemic. This is something that we're now seeing trends emerging which have been entrenched for some time. The causes of this are complex, they're upstream, there's no simple answers. It's rooted very much in wider determinants of health inequalities and other trends. Life expectancy and healthy life expectancy are showing similar patterns. Thank you.
Thank you, Chris. So we're going to have questions and moving into the panel after our presenters have spoken. So if you've got any thoughts in mind around what you've heard, obviously you'll get an opportunity to talk about that later. Thank you, Chris. We're moving on next to Dr. Mike Hunter from Sheffield Health and Social Care Trust. And I think, Mike, you're going to also be touching on the primary care mental health services.
Great, thank you. Thank you. I mean, I guess I really just want to start off by agreeing with Chris on a couple of things. As a specialist, we absolutely need to do more outside of those specialist contexts and get much more upstream. And secondly, that concept that Chris described of intergenerational or transgenerational trauma, where you see not just individuals but whole communities where trauma is being passed from one generation to another for all of the predictable reasons of, you know, poor housing, various forms of discrimination, poverty, you name it, and you can just think immediately in your head where those communities are in Sheffield and what might we do about that if we could get more upstream. So I just wanted to sort of acknowledge that from the specialist perspective. Okay, this is us on a page, and our vision at SHSC, Sheffield Health and Social Care, is to improve the mental, physical and social well-being of the people in our community. So that's good, isn't it? Because that's the sort of thing that you might expect to hear in a health and well-being strategy. And our really high-level strategic aims are to deliver outstanding care, to create a great place to work for our staff, of course to make sure we use our resources efficiently, and to ensure that our services are inclusive and that we are driving to reduce inequalities. And I think in particular those high-level strategic aims taken together suggest two things. One, we've got to work in partnership. Two, we've got to get far more upstream and engaged in understanding the wider determinants of health, rather than just dealing with the consequences downstream. Our priorities this year, and people that are familiar with the NHS operating plan and so on will recognise these conceptually, are to recover our services and improve efficiency in the post-pandemic period, to be committed to continuous quality improvement, to transform the things that will make a difference, and then I think crucially to be working in partnership to make a bigger impact. Our values are at the bottom of this slide. I won't read them to you, but just to point out that the plane at the bottom left-hand corner is landing the values, not crashing the values, hopefully. So I'm going to keep this really brief. I'm going to talk about just three things that I think have been success stories, and also link them with the challenges and where we're going in the future. Margaret mentioned on the sort of talking heads piece to camera early on about primary and community mental health transformation, and I think it is fair to say that we are leading nationally on this. We did the work through the the first lockdowns that other places were finding hard to do. We brought together Sheffield Health and Social Care, Primary Care Sheffield, Sheffield Mind and other partners in the voluntary sector within primary care networks. We currently have 6 primary care networks with mental health multidisciplinary teams within them. They're multi-provider teams, mental health practitioners who are mainly nurses employed by Primary Care Sheffield, psychologists and pharmacists mainly employed by us in Sheffield Health and Social Care, and mental health navigators who work with our colleagues and for our colleagues in the voluntary sector. We know we're making a difference there because we're collecting outcomes that show that we're making a difference. I don't know, Nikki, do you want to say anything more about primary and community mental health transformation?
I suppose the only thing I would add is that because of when we did it, it was a very permissive environment, so we were able to really empower everyone to do something very different. So it's a completely innovative model. We've got new roles in there, we've got equality in the partnership that we practice, there's no hierarchy, and picking up some of Judy's points about voluntary sector being best placed, we're investing over £900,000 annually in voluntary sector in an equal way that allows them to do what they do best. So I just think creating that empowerment and letting people do what they need to do has been a huge success.
And we've put a lot of focus into the development of relationships and trust and shared purpose between organisations, I think. Okay, so a second thing in Sheffield Health and Social Care is we've been quite innovative with new roles in mental health. Doctors, for example, can be really hard to recruit, but we've led a national programme for the development of physician associates in mental health. These are roles, these people aren't doctors, but they come from backgrounds in biomedical science, and they are a profession in their own right and do many of the things that doctors may have previously done, and we found that really, really beneficial, particularly in relation to promoting the physical health of people with mental health problems. Another example would be clinical associate psychologists. The route normally into clinical psychology is a convoluted one that includes a research doctorate. This is an apprenticeship-based model to make that profession, I guess, more accessible. We won a Health Services Journal Award for that last year, which was good news. And then the final success, this is a bit more sort of generic, I'm saying quality improvement at scale and at pace. You know, cards on the table, going back 3 to 5 years, we had some really serious issues with quality. We've come a long way across our services in a short period of time. That's acknowledged by the CQC, the regulator, and also by NHSE. We've really put our eggs in the basket of quality improvement. When you move around SHSC, you'll see our teams using QI driver diagrams to inform the improvement work that they're doing. And we've just stood up our first internal QI collaborative across very many teams, focusing particularly on the access and waiting times question. The screen in front of me is different to the screen up there, so it's one of those kind of neuropsychological tests that I'm doing at the minute, but I'm doing all right. Challenges. Okay, so yeah, building the workforce, recruiting and retaining across the whole of the workforce is an issue in the NHS full stop, not just in mental health. We are doing loads there, working locally, nationally, internationally. We're getting lots of support. We're doing the innovative stuff with new roles that I mentioned. Our vacancy rates are coming down, but I think we're aware that is going to be a constant job of work. That's not going to be something where we get to a kind of steady state and somehow it sustains itself. I think that's something that we'll always be on. Capital, you know, the money to build things with and our estates, capital in the NHS is a challenging subject at the minute, to say the least. Getting money through to improve buildings, particularly in mental health services and primary care, is hugely challenging. And then finally, access to care. So what I mean here is waiting lists, which everybody knows about. The optimism there is, firstly, as I said, we've built an internal QI collaborative to particularly look at that. Secondarily, earlier this year, we did some great work with our voluntary sector partners on one of our biggest waiting lists for the single point of access and emotional wellbeing service, and we halved that waiting list in a few months by finding a better offer for people within the voluntary sector. So there are challenges, But these are also areas where we know we're doing stuff, so there's, you know, a cause for optimism. And then the ambition. Well, person-centeredness at the heart of everything. And I put it there because I was thinking, person-centeredness is probably hard to do from the point of view of organisational isolation. I think, you know, sort of secondary care out here maybe needs to get a bit more in here if it's going to become truly personal-centred. And also, person-centeredness means seeing people through a number of different lenses and seeing the whole of the person, and that really implies partnerships across organisations to achieve that. So related to that is integrating pathways across and beyond Sheffield. Some services are commissioned and provided differently at different layers, some in Sheffield, some at the level of South Yorkshire. So, for example, take eating disorders, that there is a line between what happens at the Sheffield level and what happens at the South Yorkshire level, particularly about being admitted for specialist inpatient care. Sometimes people's experience of negotiating that line is poor, and our commitment is to work with our partners to get rid of those lines from the patient's point of view, from the service user's point of view. There should be no lines. People experience handoffs where they should experience seamless experiences of care. And then finally, partnership across the age range, how we come together as a group of providers in Sheffield, not just to talk about, you know, 0 to 16-year-olds, 16 to 17-year-olds, 18 to 100-year-olds or whatever, but how we recognise that the needs of children and then young people and young adults, working age adults and older adults, there are overlaps, but there are also some differences there that mean it's well worth investing a bit in thinking about how we work as partners to focus for the best possible offer for those different groups of people. And that is it. Thank you.
Thank you. So we've heard of a few kind of recurrent themes, haven't we, already, just with the first two presentations. So that's really good to hear, because we can see that synergy that's building. So I'd like to now introduce Professor Mark Cobb and Carmen Tully from Sheffield Teaching Hospitals.
Thanks, Heather. Some people are surprised sometimes to find Sheffield Teaching Hospitals in a space like this, because we deal with bits of bodies, don't we? You know, we'll give you a new hip, or sort your heart out, or get your diabetes on track. But as Chris has eloquently illustrated, the physical and mental are completely interrelated, and the interplay is complex and serious. So the organisation has been on quite a process to really fully engage with that and to take that on board and to begin to change its culture and approach to the way that we care for people with mental health needs. And it's fundamentally about caring for people as a whole, which is a bit of a theme. So just a bit of context. Last year, in our hospitals alone, of which we have 5, we cared for 37,000 patients who have a diagnosed mental health problem. Some of those have serious mental illness, some of those are detained under sections, some of those are deprived of their liberty through adult safeguarding. We cared for 1,300 people last year with learning disability, autism or both. In our accident and emergency department, over 2,500 people presented with profound mental health needs, some of them in extreme crisis and distress. And in our community services, and it's interesting, we touched on respiratory conditions earlier on, and we actually have a small mental health team specifically to care for patients with respiratory conditions who have mental health comorbidities, and thus it goes on. So it's a core part of our business, mental health, is what I'm trying to say. It's unavoidable. And we've built a team now, and a leadership team, which Carmen is part of, to take this forward. So some of our challenges, we've already touched on the physical health inequalities for people with mental illness. A lot of those people will develop physical problems that do require our care and attention, that they reach that level of need, that they require specialist clinical input. So again, we're often part of their pathway, we were never designed or commissioned to provide that. So it's one of the things that we are developing and evolving, how to best care for people as a whole to treat their mental health alongside their physical health, because we won't get good outcomes unless we do. And a particular issue that faces an acute trust like ours are the people who present with complex, persistent physical symptoms. This has been touched on already, but just to repeat the statistics, 20% of GP consults, 50% of referrals to secondary care, and 25% of all frequent attenders at medical clinics present with persistent physical symptoms. So these are bodily complaints that we can't adequately explain by organic pathology, but have profound consequences for individuals. They're distressing, they're long-term, they're disabling. And we spend a lot of time with patients like this trying to understand them and to provide them with help and support. And then more locally, just as an organisation, in terms of some of the challenges that we're having to deal with, Carmen's just going to say a little bit about what's happening in A&E, for example.
So yeah, some of the concerns, challenges that we do have, the lack of alternatives that we have to A&E. Most services are 9 till 5 services, so I haven't got the data in front of me, but I think most mental health presentations, crisis, does come after 5 o'clock when those services have closed. It kind of links in what you're saying with a long waiting list. If people aren't under a care team, don't have allocated workers, do they come to A&E for that safe space? I know we've got the Sheffield support up now, but that again closes at 12 o'clock, so then people may still come to A&E if they're needing that support, especially in a crisis. That kind then leads on to our workforce. Our workforce is predominantly general nurses, doctors. They haven't had that mental health training or sufficient mental health training in like managing people, mental health, how to communicate, and it's their confidence, and it is still that stigma that we're still up against in general hospitals. The other challenge is that complex patients with mental health, autism, learning disability, is the lack of mental health beds. We have to admit patients to our wards. They might be there for days when they don't actually need to be there for a medical reason. It's just the lack of a mental health bed for us to transfer. Or is it a specialist bed? Is it a tier 4 bed? But that leads to longer delays. The patient's not getting that mental health treatment that they need. And then the safer environment. Again, it's a general hospital, and our hospital is not purpose-built for mental health. So things like ligature points, we really need to be looking at that because we're putting people with a mental health difficulty in general wards.
Thanks, Carmen. So we came up with 6 kind of barriers, and Heather's been telling us to make this challenging. I mean, the first one is an obvious one, but I always think it needs restating, which is we've got to shift culturally away from this false duality. It's still very present. And it's certainly present in the way that some people relate to us. And that shift needs to happen across the board at all levels. The second is, as people have talked about, the kind of record demand for particularly acute services at the moment. And you know, we have to deal with what's in front of us, of course we do, but we mustn't let that distract us from this long-term goal and aim. We have worked quite hard, I think, at trying to situate Sheffield Teaching Hospitals in that bigger picture. People, they're with us for too long sometimes, but it's still only an episode that they're with us for. They live their lives outside of us, but we're part of that pathway. And it's absolutely right that we are situated in that and link in with that. I think perhaps at a higher level, one of the barriers is around how we commission at that population level. I mean, that's been echoed in so much of what people have said. You know, do we have the right data? Do we have the right analytics? Do we understand? Have we ever mapped out where people go on their life's journey with mental and physical health and the many, many services that they use and how they interrelate or don't interrelate, which is often the case. Clearly, we're operating in this new environment for the NHS ICBs. They were born at a time of not great circumstances, let's face it, and it's not going to get any better, is it? But how do we evolve collaborative leadership? How do we ensure that whilst the ICBs are very focused on things at scale, we can still empower neighbourhoods and localities, which is where the health stuff really happens, as we know. And that's a challenge for us all. And the final bit is this, again, echoing what other people said, shifting to prevention and upstream. And how do we ensure that even as an acute trust, we're an anchor institution, this matters to us as well. Given the reach that we've got across the city, how can we promote that and get more involved in that? So just finally, the STH vision for mental health, which has 3 elements. Again, like Mike, absolutely is grounded in person-centred care, absolutely is focused on good outcomes that include physical and mental health. It's absolutely focused on kindness and compassion. We've heard that in the video presentations time and time again. But that gets you so far, and as Carmen said, we also want to equip and upskill our staff to be much more able at recognising and responding to mental health needs. And finally, however good we get at mental health care and STH, we're only one piece of a jigsaw, and we need to absolutely walk in step with everybody else in this. So thank you for your time.
Thank you, Mark. Again, there's some themes coming out, aren't there? But that collaborative leadership one, I think, is a building theme. And I think that if Steve were here, he'd be talking about parity of esteem. But I think it's shifting our understanding of parity of esteem into that collaborative space, isn't it? And understanding a whole person's needs. So I'd like to next introduce Dr. Jeff Perring from Sheffield Children's Foundation Trust. And Jeff's going to talk us through some slides prepared by Dr. Shatha Shabib, who wasn't able to join us today.
Thank you very much. So yes, understanding, so apologies for that. So Sheffield Children's is the provider of Tier 3 cans for Sheffield and Tier 4 cans for South Yorkshire. I could just say it's very similar to what Mark and Mike have already said, and just end the presentation there, because so much of what has been said from an adult point of view is reflected in what happens from the sort of children and young people. But actually, I do want to just sort of take us through a little bit more as we go forwards. So we're very proud of the camp services that we provide and the work that they've undertaken and their developments that have happened over the past 18 months or so, particularly in light of the challenges of these times. As has been described previously, we can't underestimate the effect of COVID-19 on children and young people, and particularly on their mental health. If we add social deprivation on top of that, it becomes incredibly challenging. So the first thing is that these are very challenging times. As with others, we have the recovery to think about as well. And in amongst all of this, we know that there are children out there and young people who require help and support. So in this first slide, we just want to highlight some of the developments that have been undertaken and want to bring to your attention. Apologies that it is quite small. The version I have is somewhat bigger, so apologies for that. But we wanted to bring this to your attention. One of the main things for me about the Trust is that it's an integrated organisation. We undertake physical, mental health and community health for children and young people, both within Sheffield and across South Yorkshire. And it's really important that that integration is seen at all levels, and in particular that parity of esteem between physical and mental health is seen by that integration of physical and mental health. As an integrated organisation, we should be in a better place to do that. And just over the last sort of 2 years, we're really starting to see some of that come to fruition. As a couple of examples of that, what we're looking at is our community intensive support team, which has developed in both the scope and its offer that it can provide. So it's become a much more sort of integral part of the work that we do, both within the acute site, but outside as well. But also our eating disorder team, the eating disorder pathway that has been supported by a strong team that we've put together and has developed again over the last couple of years. That has been helped by the experience and expertise that has developed within our physical health boundaries as well. So we have a paediatrician who has a particular interest in eating disorders, and we've now got a psychiatrist who is supporting her, so that we've got both of those interlinked within an acute hospital, which enables us to actually take children and young people with an eating disorder. If they need an acute physical sort of support, we can give that support. Once they don't need that, we can then move them somewhere else preferably into the community where they can continue to have that support provided for them. I think that is a really important part for us. But also the developments that we've had with our partners, for example, the Provider Collaborative, which has developed over the last 18 months. And with that, there have been a number of impacts. In particular, the number of young people who've needed to go out of region for their inpatient care is halved and has consistently remained halved. So there are less young people that are further away from home. So actually, we're trying to keep them as close to home as possible. To do all this, we are developing our workforce so that the new roles that are described there have been developed within Tier 3 CAMS, and like Mike, we've got a physician's associate who actually has made a big impact within our Tier 4 CAMS unit. So again, really important developments that we have that we can take forwards going into the future. This was very much done as a pilot, but actually their benefit is seen, and we can sort of continue to develop that. We've been involved with international recruitment as a short-term development to help support our nursing staff. Again, a really positive experience and a positive process. Yes, we need to be able to improve training and education and bring people in, so homegrown staff, but in the short term, international recruitment has helped and supported us. But beyond all of that is co-production with children and young people and their families. And again, one of the areas that we've been really sort of supported by is Chili Pep, who have helped us to really gain that insight and continue to do so. We've worked with them for quite a long period of time, and we continue to work with them. So very positive from that point of view. We recognise there are still things to be done. I don't think anyone here would say anything other than the 16 to 17-year-old interaction between ourselves, STH, SHSC is perfect. It still needs more work doing with it. But again, you know, we're starting to work in partnership to take that forwards. And I think that's, again, positive. And the only way we're going to be able to resolve situations like that is by working in partnership with each other. So over the next 3 years, we want to build upon the work we've already undertaken to improve access to our services. We know that our waiting lists are too long, and we need to work on that. But in doing this, we want to ensure that inequalities are addressed, recognising that we can have unintended consequences in trying to improve access. Actually, we can have unintended consequences whereby those people that get that improved access are not the people who necessarily need it most. And actually, social deprivation may well have an effect on that as well, in terms of things like, you know, sort of ability to do online sort of work and online sort of, I'm going to say meetings, but, you know, to take that forwards. So that's really important. And we have to make sure that those two areas are going hand in hand. Inequality, watching inequality, again, with improving access. And in doing so, listening to the voice and co-production with children, young people and their families. So again, to make sure that that continues to be present, continues to actually inform what we're doing, to make sure what we're doing is right. And finally, to support all this, we do need to continue to develop our workforce so that our CAMS service is both a place where people want to come to work, but also where they want to develop their career. It's one thing bringing people in, but we've got to make sure that we retain people that we do bring in, and actually they see it as they can progress in their career within the CAMS service. So that actually our final sort of position is that we want to be outstanding, and we want to provide outstanding care for the children and young people who need us and require our services.
Thank you, Jeff. Again, there's some recurrent themes that social deprivation's coming across and that inequality of access. And I think this is something that all organisations are going to have to really pay some further attention to in this coming year, because we know that some of those communities that really need those inputs aren't getting access to it. So now to bring us into presentation from Helen, who's going to do a verbal presentation now, and Helen's bringing together a number of voluntary sector partners and initiatives that we've got in the city, and I hope what Helen will say will kind of mirror some of what's already been said by our NHS providers, because it is about the glue that binds us all together quite often in terms of what the voluntary sector is offering in the communities. So Helen, over to you from us.
Thank you. Yeah, absolutely. What I want to do actually is just rehearse what the VCSE does in Sheffield, because actually there are some recurrent themes about being upstream, getting upstream and getting into that space of actually stopping people needing to be in a hospital or to access services. But also I think just understanding the importance of people getting support in their place in a relationship-based way, and the multiple types of support and the interplay with lots of different needs, and just thinking through what the VCSE do in Sheffield. There's a whole host of organisations. We have a really diverse sector, 3,500 organisations at the last count. Many of them are supporting people with health and wellbeing, with health creation, but also with some really complex and kind of multiple needs that span poverty, mental health, and a whole range of issues. So I'm just going to rehearse some of that. So what do the VCSE do? Well, they wrap multiple types of support around people in local communities and communities of interest, which may be groups of people that exist at a kind of pan-Sheffield level or in certain parts of Sheffield. That includes support with mental health, but it can also include physical health, confidence building, support with food supply, income maximisation, growing workforce, employment and skills, housing issues, social connections, isolation, spotting vulnerable people and actually picking them up, supporting with early years dementia, end of life, frailty, and creating the physical meeting spaces that are really important to mental health, as well as building community strength. So that's quite a long list, and it's not an exhaustive list. There's a whole range of other issues, and often these things are provided in a single setting by an organisation. So I think that's really important to this conversation. Other things that I would like to draw out, the VCSE builds on the positives in communities to help people to understand and access opportunities, and can be good at connecting marginalised and disenfranchised groups of people. Building community cohesion and bringing people together around common aims, recognising assets in communities to enable people to live healthy lives. Also enabling community data and insight to be heard and understood at different levels across Sheffield and South Yorkshire. And I think this is an area we've touched upon, data and insight, but actually sometimes the data and insight from the VCS gets overlooked, and it's really important and can be really instrumental in doing things in a much more effective way, in a much more targeted way. So opportunities, I think that immediate reach and connectivity with people's health has been key to providing some really successful support and some successful partnerships. Mike mentioned the mental health waiting list project. That's a really good example of how the VCS can work with the statutory health and care system. What would help it is if it had longer-term funding, so we could actually sustain that, because it was supported by some short-term funding, and I think that's about to end. Other opportunities around providing this type of support that creates health and gives people more ownership of their health outcomes, which is really important. They bring agency and trust. Lack of agency affects health, and it also has wider social and economic impacts. The VCS also bridges gaps in policy and delivery, as well as bringing it together. There are gaps that just don't get met anywhere else, and can extend reach through culturally appropriate support and a whole range of other ways of connecting to people. So, for example, bringing support to people who are autistic in supported spaces that are right for them, connecting voices in a different way. So we've got some really good examples in Sheffield that we can build on, like the Changing Futures programme, the collaborative conversations work that was mentioned earlier. That takes place in communities and brings in different voices that don't necessarily connect to other types of engagement. The VCS is also really good at interfacing with the work of statutory organisations, making itself fit to create more opportunities for cross-sector partnership and bringing together assets. We've heard about Synergy as one of the collaborations that's been developed in Sheffield, which is connecting wider voices into understanding how commissioning and investment is made. And actually the VCSE has got a unique position in some ways in leveraging different types of investment into the city. In VAS we've been leading some work which is supported by Health Education England money to upskill the VCSE workforce in mental health first aid, clinical supervision skills. So I think there's something really important about understanding opportunities for bringing together that opportunity with the money that kind of comes down from NHS England or from, from public sector sources. And I think something that is really important, and we've seen this in COVID particularly and the lockdown period, that the VCS can alert early when things are starting to go wrong. And I think that's another area where we could explore more opportunity for partnership working. Challenges, I usually start with challenges, and I've actually, I'm going to go through them, but actually I think that for each challenge there's an opportunity and we can work through that. But the VCSE have been reporting that they're supporting increasing numbers of people with complex mental health needs, and that's symptomatic of the strain on services, and that's something that we need to think about. I think traditionally we think about the VCS as being nice people who provide, cups of coffee and a chat. Actually, they do that, but they do an awful lot more, and they're dealing with some really difficult support needs, and they're not resourced to do that, but they do it anyway because they're connected to people in their community. And there are vast disparities actually in need across different communities, as Chris has highlighted, and I think that we all are aware of that, but the investment in the organisations in those communities, and particular communities of interest, is vastly different as well. So there are some inequalities around that we really do need to think about. Navigating short-term funding, insecure funding, limits how we can meet ambitions, not just for securing the VCS, which is really important, but also for some of our city aims and ambitions, like the Mental Health Community Framework, NHS England 5-year plan. It's very explicit in talking about moving into doing more in a community setting, so actually we need to really sort of think seriously about the VCS role in that. But also in a way that doesn't drive competition, because actually competition for funding, particularly driven by commercial procurement approaches, can actually undermine the potential of collaborative strength-based working, and it can reduce the sustainability of our local VCS, because they're not necessarily there to have really fancy, bidding processes. That's not necessarily what we want them for, but they do lose out to organisations that have just got more kind of bidding and muscle around procurement. And actually, costs are not often met in funding models, so it puts the organisations under a huge amount of pressure. Again, that's something we can sort of build into the way that we work as a partnership with the VCS. And I think move to a much more sustainable model of funding, but we've got some good things happening again in Sheffield. So the work that's been developed through the Health and Care Partnership around community development and inclusion is an opportunity to really connect into a way of working, and that sits across all our work and is an area where we're developing principles. We're getting to an approach that actually, I think, gives guidance to all of us as to how we can work in a much more effective way. There are other wider challenges, and I'm not going to go through all of them because I think I've probably picked up quite a few, but I'd just like to kind of end with, I think saying that the way that we see people's needs and we see people and the solutions, it's really important to not just invite the VCS to meetings, but to actually look at different ways of understanding how we design models that are based on people's needs and talk to people in their place and in their communities, or have conversations that are supported by people who've got agency and trust to develop our sort of collective solutions and ways of working. Have I gone over 7 minutes? I'm like, yeah. So yeah, I'm going to leave it there. Thank you.
Thank you. Again, there's some challenges in there, and keep those in mind in terms of that collaborative working, again, that we've been talking about, and that prevention. I'm now going to introduce Tim Gollins from local authority, who's supported by Tanya Bowden and Sid Fletcher, who are sat at the back there as well.
Hello.
That doesn't match. It's just that one.
Okay, which ones? Hello, everybody. So there's a disadvantage to coming last after a series of presentations and an advantage. First of all, the disadvantage is you're all a bit fatigued, probably. And the advantage, though, is there's lots of themes that are going to come out, that are coming out, and I think you'll see those through this presentation. There's only 3 slides, so stay with it. First off, I'm going to do something a little different. I'm going to focus on some of the specifics around mental health and social care, and then I'm going to broaden it out to sort of city and social issues as well around mental health in Sheffield. So the first thing to mention really is the obvious, that with a social work lens on this, the statutory social work lens, the mental health transfer happened on the 1st of April, where the staff came back from the Mental Health Trust to the local authority, and that went very well and has been very effective. We've got some challenges in terms of allocation of cases and reviews, but actually we're working very well with the staff. There's a definite plan to address some of those waiting lists in terms of developing full recruitment. And that's a common theme, isn't it, about workforce. That'll be something I mention on the next slide as well, that is a really clear challenge for the sector. But also we're developing training development for the staff. We're actually focusing on strength-based approaches to working with people with mental health problems and being very person-centred, and that's also a common theme, developing those very specific skill sets. And we heard that in some of the videos that we listened to earlier. And then the other thing I just mentioned off that list is interfaces. I think things go wrong at interface points. So it's often from the acute sector to the social care sector, from the social care sector to the community, and where people develop their independence. Often things break down and people end up going back around in circles. So that's a major point. And I'm talking about organisational interfaces and also social, within organisation interfaces as well. Some certain things that are going really well. We've got a new information advice and governance and guidance platform, and that's addressing 50,000 hits a month now. I think it was very low when it was previously something else. So that's very good. And we've got really good and high functioning first contact services and a new multi-agency safeguarding hub, which is being very effective. And of course, we've got really strong partnerships with the ICB around our Section 117 work, and strong partnerships with primary care and continuing relationship with the SHSC and in Sheffield Teaching Hospital. Okay, so moving on, some of our mitigations and challenges. That's a bit smaller than I thought it was going to be.
You need to sit here.
Okay, so some 5 key sort of challenges, and I've listed some of the mitigations. So first of all, we've got to improve our statutory performance, okay? And that's challenging in a financially constrained environment, but we've got that managerial focus and we've got that leadership and support, so we're getting on with that. We've got to embed wellbeing centrally into assessments and support planning process. That's that practice development programme that I alluded to. We're getting on with that as well, so that's developing brilliantly. But there's a real challenge about balancing the risks faced by people in communities and the risks of people delayed in hospitals. And that's a constant issue that we're managing on a daily basis. How do we deliver our resources? Where do we put our emphasis on our social work effort? And that's a challenge. We've got to get expertise at the first point of contact to help people remain independent as well. And that's about focusing on prevention and early intervention. And that's a challenge when you've got that downstream duties to deliver on. And in maintaining that focus on prevention, how do we invest in the voluntary community sector whilst also delivering on those statutory duties? That's a really key tension and well recognised, I think. So the broader elements, we've got that workforce challenge, and I think that's been mentioned a few times, but it's a broad social work challenge, but it's especially a challenge for specialist social work roles. They're really difficult to recruit to. We've got to expand our commissioning. So we struggle often with getting good providers of supported living, and we struggle perhaps even more with specialist providers, particularly around personality disorders. Having said we've got some commissioning challenges and workforce challenges, we've got to embed some continual practice changes about co-producing. So we're actually designing solutions to some of these problems with people who use services. And we've got a really good departmental approach to co-production, but we need to continue that development. More generally, we need to demystify mental health a little bit and get more education and understanding across the workforces and into communities in general. And I think we've got to sort of focus on more psychological and relationship-based societal impacts rather than necessarily focusing on medics and pharmacology. Or maybe some of my colleagues might disagree, I don't know. Obviously, the latter is very important, but I think the emphasis might need to switch a little bit. And finally, there needs to be a focus on communities, on self-help groups and supportive communities, because actually if we're going to deliver really good social care, statutory support, social work, we need the people in communities that can respond to situate people's well-being in places, because it's difficult for the statutory sector to deliver on well-being. Well-being is quite a diverse concept, and people need access to good quality communities. Okay, I think that's it.
So colleagues, we've kind of finalised our presentations there. We have run slightly over on that section, but the next section we're moving into is a question and answer time, and thinking particularly from a Health and Wellbeing Board membership perspective on what the difference is that the Health and Wellbeing Board can help system partners to galvanise in the city, and thinking about the challenges that we've heard from our providers but also from our service users earlier. So you've heard and seen a lot. Now's the opportunity to just reflect a little, but also ask some questions from the expert panel that we've got in front of you. So open it up to the floor, Chair.
Thank you. I thought Josie was going to moderate this. So we have about 20 minutes for questions. We've run 9 minutes over in the previous session, but I think we can squeeze the last bit in a shorter time, so we'll see. So all the people that have presented are ready for your questions, so have I got any kind of Councillor Dale?
Thank you. I wouldn't be in a room if I didn't mention young people. I won't be doing my job appropriately. And we talk very much around the community approach to mental health, which is going really well in many communities, with voluntary and community sector, delivering a lot of that very, not front door stuff, but garden gate stuff, the stuff that people get to before they've even gone to the front door. But we don't do that for children and young people. It's very much adult focused. And I'm just wondering what the plans or thoughts are around offering a similar sort of community model for our children and their families as well as the adults. Thank you.
Who wants to take that?
Thank you. Yes, we do need to provide more sort of community-based models. There is some around. So it's not that we're without, but we do have Door 43 and the work that they do. We do have the work that was described right at the very beginning, going into schools, and the work that, sort of going into schools. Certainly part of our sort of development over the coming years is much more place-based, rather than it being just sort of centralised. So yes, we can do more. We are doing some.
If I could just come back, thank you. I do know about Door 43 and the things that are happening in schools, but a lot of the young people that I work with don't access school because of their mental health. So going into a school to access service is quite traumatising for them. So I would just think if we could have a further conversation across the sectors around how we bring that into communities like we have done with the adults, into community buildings and community assets, maybe through our family centres or other community buildings. Thank you.
Yeah, it's just on that, one of our frustrations in the primary community mental health bit has been it's been adult focused because of the National Commission. So we've had an awful lot of investment into achieving what we've done, and it's been very successful. We know when we talk to SCH colleagues at the Children's Hospital, that we could do more in that space as well, but the funding hasn't been there and it hasn't been commissioned. So it'd be great if as a board we could get something from you to influence that and take that as a next step.
I have Lee for a question.
I feel like I've been cancelled. Thank you. Thanks for the presentation. I feel, given all that we've heard this afternoon, this as a board could be the most important presentation we hear all year. And I think we've got to take that on board. You know, all the data that we've listened to, it's vital that this gets a response. So thank you to everybody and to everybody else who contributed on the video. And I feel a bit conflicted because I really like innovation. We want to be positive. We want to celebrate where things are going well. And so anything I say is not in any way detrimental to that. You know, the joined up working, the innovation, doing things differently, trying to get upstream, absolutely is the way we need to go. But we haven't really touched on how terrible it is at the moment. And it really is terrible in terms of, not in terms of the quality of service that people get, it's just access. And that's not about, it's not in any way decrying what is being offered. It's about actually how is it funded? What are the priorities in this city? And what are we doing about it? And I think that, again, falls back to this board to have a think further about this and see what influence we can bring to bear on it. I think that mental health underlies the whole of not just healthcare, but well-being as well, and we're all sort of nodding our head. It's like we all know this. It feels a bit like climate change. It feels a bit like inequality. We know this stuff, but then we carry on doing what we've always done. So I looked at the data for PCNs. So people who don't know, PCNs are clusters of GP practices that are brought together in order to look at things on a slightly bigger footprint. For every single one of the PCNs, the outstanding health problems are depression, obesity, and high blood pressure, apart from the most affluent PCN, and then asthma kicks off obesity. But depression is there. It's not cancer, it's not heart disease, it's not stroke, it's not musculoskeletal problems. And I would argue that that actually sits under all these other health problems that we know. We've just said, 50% of referrals and outpatient appointments have an underlying mental health issue. I can't remember all the statistics that you gave, but a lot of people who are inpatients, there's an underlying mental health issue. And I would slightly push back about I understand exactly what you mean and really welcome all that SGH is doing, but we're not commissioned to provide this service. I know you weren't just meaning, there is severe mental health problems that occur in A&E that actually do need mental health specialists. But I would argue that actually we are all commissioned to do this. Mental health is part of everything we do. So when I did my GP training, I hadn't had a mental health job. I'd had standard training and ended up in general practice. I soon realised that I needed to get trained up because it's such a big issue. And I think we need to make sure, it's our job to ensure that everybody has adequate training and is upskilled in a way. Otherwise, we're not only doing a disservice to people who are using the services, we're making our lives and our staff's lives really, really difficult. So that is definitely, really interested to see where we can go with that. I think, I could go on, but I won't. It is about parity of esteem, and we say that, it trips off our tongue, but we don't have parity of esteem in terms of funding at the moment and the way that the services are offered. And I think, we've got serious questions to ask ourselves as a system. And as well, the inequality of access. So we were talking this morning about, at another meeting I was at, that the NHS is really good at equality, getting access equally, but it's not fairly. It doesn't always match need. And I think, again, as we're thinking about going forward, how we're going to tackle all these problems, having that inequality of access, not meeting need, needs to be central in our thinking.
I think Mike is going to come in.
Thanks. Okay, so this is a bit of an oversimplification, and it's not just a Sheffield thing, and it's not just even an England thing, but by and large, mental health gets about 10% of the money for about 25% of the problem. And in saying that, I'm not arguing that specialist secondary mental health services should get all that. Clearly, it's about looking at it in the round and making sure that in a given health and social care economy, that the resources are being allocated in proportion to the level of need. So that's just a way of saying I agree with you, Lee. I think, and Greg, I think in the kind of the preamble with Heather and co talked about bringing that sense of challenge. So I think there's a challenge for all of us. I as a provider wouldn't say this is a challenge for the Health and Wellbeing Board or for the Healthcare Partnership. This is for all of us. We've all got skin in this game. The challenge is, what does that conversation with our communities in Sheffield sound like if we were saying we're going to do this and we're going to value it and we're going to allocate resources in proportion to need? So what are we going to do differently? What are we going to do less of? And what might we not do at all as a consequence of that? And what would that look like? And are we bought into that as a whole community in Sheffield? And how would we lead that between all of us?
Thank you. Greg, did you want to come in?
Yeah, thanks. So thanks, Heather, and to the team. Immense effort, and it's really, really comprehensive. And I'll kind of write properly later, but thank you. Really comprehensive overview, and I feel pretty assured actually that we've got the right strategy, notwithstanding that we know we've got some problems. We've got some amazing good practices as well. So let's reflect on that. I thought there was perhaps something more to do on employment and mental illness as a constraint to employment. We know we've got pretty good story there, but the whole mental illness and or lack of mental health as a constraint to employment, which is a fundamental determinant of health, I think probably something to expand on there. Clearly you've celebrated on the good we have, of which there's plenty, and Lee's said there are some gaps, and we know we've got gaps and holes, which are largely resource constraints and perhaps skill and permission issues. Just one other thought on determinants of health. A fair few talked about the determinants of mental health. The strategy is framed in the totality of mental health and wellbeing in the city. We've had a long conversation about many aspects of the NHS. I don't think anyone should expect the NHS to fix poor homes or homelessness, but we've got important things to do there. I don't think anyone should expect the NHS to fix lack of work, but the NHS's fingerprints are all over Working Win and IPS, etc. Ditto, the Children's Hospitals Trust fingerprints are all over our approaches to ACEs and trauma and things of that ilk. So the NHS can, does and is addressing the determinants of health. Other parties have to do their bit. So I'd end with I think we've got the right strategy, and I feel pretty assured we've got the right strategy actually, and a lot of stuff that's within it. We know we've got problems, but we know how to address those problems, and our job is to then work out the what next and collectively hold lots of bits of feet to lots of fires. I'll pause there.
Thank you. I have Catherine and then Judy.
Yeah, thanks for the presentation today. It's been really good to hear from real people for once, which is really nice to do. One of the threads that's run through it, and I would say this was like coming from the Healthcare Partnership, is that importance of partnership working and how you can't do that person-centred work without working across boundaries, services, organisations. That doesn't happen by accident, and our staff need supporting to work in that way. I just wondered from the contributors today what you're doing in your organisations to support staff that maybe aren't used to working across systems and across organisations, what plans you've got to upskill them in that area.
Does anybody want to answer that? Thank you.
It's a bit easier for me to answer this because we're actively doing it, and perhaps say that's where we can share the learning because we're not doing it as well across all the organisations. So we started off our transformation work with new posts, which always makes it easy because there was no upheaval. But it has been working across two organisations. And as we're getting into the next phase of the primary community mental health transformation, where the two organisations are coming together, we are now starting to see those organisational cultural clashes. Primary care manages risk very differently to secondary care. We manage waiting lists we don't have waiting lists in primary care, we just manage a load of patients and hope for the best and vice versa. And actually what we're doing now is a series of workshops and conversations that starts to find out what's the middle ground. And the best part of that is we can use both. So there isn't a threat to anyone. Everyone's got their contracts, everyone's working in the comfort, but they are now getting permissions to act in a way that they weren't before. So it's creating that psychological safety to speak, it's creating the culture of safety to act, and then the reassurance that they're going to be supported and to do the job that they want to do best. And I think that's the bit, it's working with people. But I think probably we've got a task to share some of that learning as we go.
And moving it a bit from who do you work for to how are we working together in this shared space around a shared set of objectives. And that sounds all just great, and then we've got to work out all the governance that goes with that, which is complex.
I think there's a challenge as well that we have to, it's holding the mirror up to ourselves, isn't it, this? I sit on many groups and many committees where people are committed to work together, but when push comes to shove, we often go back into our own organisation. And there's something to me about us galvanising that leadership. A couple of tangible examples. We've touched upon eating disorders earlier. There's some system issues that we need to sort as partners between us, and that's partly around the fact we've got different providers, as you said, with skin in the game, Mike, earlier. How do we actually solve some of those problems when we know there's some chronic underfunding? And just kind of picking up on the points that I think Mark alluded to earlier, we got a business case recently asking about one particular specialty within the teaching hospital around psychological support. Coming to the mental health commissioners that haven't got enough, unfortunately, to spend on the things that we're meant to do against the mental health long-term plans. It's a struggle. But actually, if you turn that round and say, if we did invest as systems into some of that psychological support around the long-term conditions that Chris has talked about earlier, if we added that psychological support into some of that work, or to prevent the long-term conditions by addressing the depression and anxiety that exists within the community, we would be saving money as a system. And it's how do we actually really work that through as a system? I think that is the biggest challenge to us as a city.
Tim, did you want to respond to this?
Yes, I just thought it was a really good question, thinking about it. I think, being really honest, we've got a very good workforce development programme within adult social care, doing a number of things around how we want social workers to behave and how we want them to do the job. And we've actually had a recent partnership event with SHSC where we started looking at some of those interfaces. But could we do a lot more of that with other partners? Yes, of course we could. And I think that's probably something we need to take forward.
David, did you want to respond or did you want to ask a question? I've got two other people before you, is that okay? Judy.
I think, as I said earlier, Healthwatch hears about mental health issues time and time again over a long time. And what people often say is that their experience and their voice, they don't feel is heard. Now, that may or may not be the case, but that is a common view. And because it's said often, I think it's probably got some truth in it. I've heard in passing points about engagement and about co-production, and that's great, but I haven't got a sense that that's absolutely at the centre of what drives these strategies. And it seems to me that engagement isn't just a nice to have, a thing that you could do. It's really central to making the changes that we've all said we want and to be really person-centred. So I'd really like to be reassured that that sense of engagement is part of that vision. That's one thing I wanted to ask, but I did want to ask as well about international recruitment. A couple of people talked about it. I sort of know what that means. Are we recruiting from really poor countries to another poor country, Britain? How does that work? And where does it fit with notions about equality? So two different questions.
Thank you, Mike.
Thanks, Judy. I mean, I'll have a go at both, if that's okay. The co-design and co-production is at the heart of it. And as you know, it's difficult. And organisations sometimes get it wrong, and it's experienced as being arbitrary, late in the day consultation or engagement rather than co-design and co-production. For us, I would say our clinical and social care strategy, which is our major strategy, and all of our other strategies are enablers for that, absolutely was co-designed and co-produced. We spoke to about 800 people putting that together. One of the co-leads for the implementation of the strategy is an expert by experience. One of the work streams in the strategy is co-production, and that's something that we're really keen to develop more widely in the Sheffield system. But I think the challenge is always welcome, because it's one of these things that I don't think ever becomes self-sustaining. It's always easy to take your eye off the ball and to revert to mid-20th century corporation type sort of behaviour, if you know what I mean. The thing about international recruitment, there are strict rules in place about that. I'll talk about doctors, just because I know that one the best. The General Medical Council has a very specific procedure that we have to follow. We have to become trained up as an organisation to be able to do it properly. We can't go fishing in red-listed countries, which are the countries that are poor and are under-producers of medics. We can recruit from countries that overproduce doctors and have doctors that are looking for careers elsewhere in the world. So it's not a free-for-all, it's a tightly governed process.
Thank you. I have Douglas and David, and then I'm going to close there. Oh, sorry, Tim. Did you want to come back from that?
I was just going to say that there's two elements of co-production within adult social care. There's about listening to people's voices when we're working with them, and I think that's the part of the practice development programme that we've got, and I think we're getting much better at doing that. And then there's a systemic co-production approach, and I think our adult social care strategy it has been co-produced, and I'd like to give you some assurance that has been done thoroughly with people who use services. On the wider question of recruitment, I think we're growing our own within the statutory sector, and we've got really good ASYE programmes, but I think providers are struggling and they are recruiting from abroad under a national scheme. I don't know the full details, but I can get them for you.
Douglas.
Well, thanks. First of all, some really interesting presentations today, and it was good to hear the voices of people. So, thanks for everyone who's put it into that. What I was detecting was this approach of continuous improvement, so that's very welcomed. Just two thoughts I had, that sort of over the course of the afternoon. And first of all, we often have this analogy, don't we, of we're spending all this time pulling people out of the river, and then asking the question, so who's pushing them in the first place? Well, often it's us. We often actually spend a lot of time in our organisations pushing people into the river. Not maybe intentionally necessarily, but that's what we do. That's actually maybe encouraging, because we could stop pushing people into the river and reflect on how our organisations could make people's lives better, just as large employers. So maybe that's something just to sit there rather than ask for a separate answer on. And the second thought that occurred to me is just really the really difficult one of at what point do we start asking the question, when do we pull back from putting so much resource into those, critical services, like cardiac services and so on? When do we pull back from that and say, well, actually, we will put more money into other areas? Recognising that actually that does mean that, some people will die earlier. On the other hand, it means that other people will live and will live more healthily. It's a really difficult conversation to have. So again, I'm just asking when we would start asking those questions, and I'm certainly not asking for an answer right now, but I'll just leave those thoughts there. Thank you.
Yes.
Let's remember that these populations are dying up to 30 years younger of preventable health conditions, the preventable long-term conditions that then the teaching hospital have to patch up. So I think your question and your comments are really valuable in the context of this discussion. We wanted to go on to talk about the kind of pleasures or the difference that today's conversation will make to this board. I don't know whether it's appropriate. Oh,
sorry, I have David who wants to ask a last.
Sorry.
It's just a question. So I think one of the challenges is where's the focus and where's the greatest ability to make things different and better? So, and because there's many dimensions, we've talked about people with severe and enduring mental illness like schizophrenia, it could be, can be severe and enduring, and bipolar disorder and so on. And then you've got a lot of people with mild to moderate mental illness. Then you've got to think about whether the interventions are effective or not and the degree to which they make a difference to people, because there is, I think, even if we put every single penny we had into mental health, people would still be unhappy and have anxiety, we wouldn't cure them all. It's not like that. So it has to be based on need, which is the ability to benefit. So, and then there's some other dimensions we looked at we haven't really talked much about. In the trust, we put it all together, dementia, learning disability, autism, because we just have to, but they're quite different things in many ways. But we have touched quite a lot on health psychology, so people with chronic physical conditions who don't manage them very well because of their kind of psychological response to it, so we could help them more, but it's not a mental illness, it's just that if you're a diabetic person who doesn't really pay much attention and finds it all a bit scary and avoids it and doesn't, we might be able to help them. It's not a mental illness, but it's a psychological intervention. And then there are people who present with physical symptoms that are real, but have no physical cause, where health psychology may or may not help. A lot of people with those conditions aren't helped, and some are. And the question is, how much resource do you want to put into that, given that for some people it won't be effective? So I think there's something about focus and where there's gains to be had by working together without spending loads of money that we haven't really got, and that is a real sort of challenge for us. And don't we in healthcare, we tend to focus on the people who are have greater levels of need, where their disease is more serious, and where we think the intervention is going to make more difference. And that's where the whole government's improving access to psychological therapies programme came from, because there were zillions of people where simple, cheap interventions to a formula were effective. When we say effective in about just over 50% of people. So not effective in everybody, but that's better than nobody. So, you know, there has to be some realism here that there's some of, I always say this, it's a bit, almost like human misery knows no bounds, does it? I mean, there's like a lot of it about. And it's our focus where we could really do the best to make things different and better. Anyway.
Can I actually say my 2 pennies worth of... yeah, I was thinking that we have had like we've touched on lots of things, and I want to go back to something that Helen said and about communities and voluntary sector organisations, because what we sort of talking across purposes, because we're talking about healthcare and mental health, and we're talking about health and well-being and the community sector. And if at the moment we are using most of our funds to cure physical health and a bit of it to cure mental health, but we're not actually investing in preventing people from getting ill, we're doing it wrong, aren't we? So as a board, I think our challenge is to ask those questions and say, we've done this way forever, it's not changing, we need to do it differently. So I feel that what we need to do is enabling, so being enablers of the fantastic work that goes into our communities, because that is where the health creation is. That's where people live their lives. They don't live their lives in hospital or at the surgery. They live their lives in their communities. So if their communities are not welcoming, are not home, they're not safe, they're not where their jobs are, they're not where their family can have a good life, and that's where we need to invest as partners, including the NHS, but not the NHS as a whole. And obviously we do need to shift, funds from physical health to mental health, because otherwise we're never going to change the fact that people are dying earlier of physical conditions because of their mental health. And I'm not an expert in health, but that is my kind of, things that have been going on through my head today with all the various conversations that we've had. Helen,
Thank you. I think that's really helpful that you've flagged that, and it is difficult to bring the VCS conversation in alongside the curing people conversation because they're so different. But I think we've got a lot of recognition in the city. I don't think this is a new conversation. It's a conversation I've had a lot, I know, in the last few years. But we've also got structures where we can embed this. So do we embed this into the Health and Wellbeing Board, that we've got a set of principles, we've got a framework which is, this is actually how we look to get into that upstream, and we're wanting to drive that from within the Health and Wellbeing Board, as well as the Health and Care Partnership, because, as has already been said, they can't be separate. We can't have two partnerships that are functioning on different rails. So yeah, I guess there's maybe a question about how do we embed that and how do we give it teeth.
I have Tim, and then Andrew wants. Sorry, Chris.
I think I was sat here reflecting as a GP, a generalist, that two things. One, you're absolutely right. What the conversation has drifted into is not health but illness and pathology, and away from creating and engineering well-being and health. And that's always a difficult thing when you've got healthcare providers. And that was the other thing that sort of struck me as I listened to each of my colleagues describe their challenges within the different organisations, was that whereas I do a surgery in my practice and I don't know what the next patient is going to bring, whether it will be a physical health problem, a mental health problem, or both, as Chris and Greg have pointed out, that I remember Greg, when he was fresh-faced here, I'm sure gave a great stat of, yes, I know, that by the age of 30% of the population of Sheffield have got at least one long-term condition, and by 50% of them have got two or more. And as we've heard today, a great deal of those people will have a physical and a mental health long-term condition. And so to some extent, when I sort of sit and listen to each of those providers, what I realise is that we've got a really fragmented healthcare landscape here. Not intentionally, but by design, we have separated out pathology, physical pathology and mental pathology, adult pathology and children's pathology. And to sort of challenge David back, I don't think it's about sort of saying an organisation has to suddenly start and do a different organisation's job. I think it's more, as Nikki was sort of saying, about understanding that that person who, by the time they reach a specialist in a specialist provider organisation, probably has more than one thing wrong with them. And you can bet your bottom dollar the second thing is probably physical if it's not mental, or mental if it's not physical. And so to some extent, it's about how do you focus on the thing your expertise at, but not disregard the other thing? And how do you pick up and acknowledge that other thing? And how can we learn from each other as partners? And that's what Nikki was describing, I think, was what I was sort of thinking. I spent 25 years, Lee, not to tell how old you are, but you've spent an awful long time as a generalist as well, managing that uncertainty of managing more than one thing at a time. And maybe there's something here as a partnership, and I know we were describing earlier on the ICB sort of relative immaturity, but where although the ICB is that commissioning bit, we're all in this ICP partnership together now. And maybe there's an opportunity in that new partnership to start to learn. I've always been inspired listening to experts and learning from experts in hospital specialist-based medicine, but maybe there's an opportunity here for some of learning in different directions, where people who become very specialised and very expertise at whatever they do begin to understand how you manage complexity, how you manage risk that goes beyond your area of expertise, by acknowledging it in the first instance and not dismissing it. And then once we start to do that individually in our organisations, we then start to work collectively much smarter together. And then we can start to broach, how do we get beyond treating pathology and even preventing pathology into how do we engineer and create wellness and well-being and health in our population.
Thanks. I have just Mike and then Heather, if you could sum up. Thank you.
So I think it's not either or, and if we do this properly and are serious about the whole range of approaches to wider determinants, then mental well-being improves in a community, in a society, whatever. For those people who go on to develop severe mental illnesses like schizophrenia or bipolar affective disorder, where primary prevention was never going to quite play the role that it would do for mental well-being more generally, they may still become unwell, but they're less likely to be exposed to those societal stresses that cause relapse and hospital admission and all that sort of thing. And in a setting like that, things are more efficient, so more resource is available to be able to do physical health well and to be able to do acute mental health interventions for people with severe mental illnesses well. It just needs that kind of zoom out to the strategic.
So, colleagues, we were wanting you to do a pledge and to discuss amongst yourselves what difference this presentation's meant today to you, or what thoughts it stimulated. You've started to share those actually partially framed in questions and comments. What I would propose is, firstly, there's an absolute read across between what Susan was talking about earlier with the health and wellbeing strategy, isn't there? So my challenge to this board is making sure that we can see mental health writ large as opposed to just 4 sentences at the end. Not that it was before, but that's what we sometimes find when people compartmentalise mental health. So that's our first request and challenge. And I think we would want from the mental health delivery group to make sure that we've got an editing author within that space and take you up on that offer earlier. Secondly, I think with regards to what difference it will have made, we've given you that resource pack as well, which will actually talk to some of the challenges that we were talking about earlier, the waiting lists, how the fact that we've got children waiting for 2 years to access CAMHS or 18 months to access CAMHS. We've got people who've experienced trauma waiting up to 4 years for specialist psychotherapy. All those facts and figures are in your pack, or if they're not, please come back to us and ask. But what I'm wondering about next with regard to the pledges, if we almost use this group of experts that we've gathered, and maybe 1 or 2 others, to maybe reflect on the questions and comments you've asked, but to ask you to complete those pledge cards that we've given, and perhaps, Chair, that's something that you can oversee to encourage that. And then we come together with a couple of key members from this board to reflect on today and to see where we can start to lever in some actions into our next iteration of our strategy and our delivery plans. And I think that's possibly, in terms of a summary around what we've heard today, what our intended outcome was to create that reflection space for you as a health and wellbeing board, but for us as system partners, because it isn't a polarised view, health or mental health, physical health or mental health, children or adults. What we're going to do as a city to address these challenges, and we can't do it just as individual organisations or individual roles. So that's how I'd just like to kind of frame that challenge, and the reflections and pledges, you've been handed cards to do that. So, Chair, if I could leave that with you for us to follow that up afterwards.
Thank you. Greg, do you want to come in?
Yeah, so yes is the short answer. Thank you for the challenge. And again, thanks again for organising. So that was really, really, really insightful. Consider hand snapped off, make volunteer available to Susan to do the writing. But yeah, consider hand snapped off. And then on the reflection bit, what next? I'll take to coordinate that amongst members of the board, tap some people on the shoulder, see who wants to volunteer. But yeah, I think we've got a lot to reflect on, and a lot of good, some problems and some challenges, and the work out the where we go next. It basically feeds into the development of the strategy.
Thank you. Cool. And can I just thank both Josie Soutar from Flourish and Robin Fletcher from Flourish, who've helped to produce the materials for today and put Steve's and our vision into reality, because I don't think we could have done it without them. So thank you. And thank you, colleagues, for listening and caring.
Yes, thank you. Can I thank everybody who's contributed today behind the scenes or presenting? It's been super interesting, and we could do a whole week conference on this and not be finished, because there is a lot to say, and there probably are other organisations that would be interested in, coming on board. I think in terms of what's next, we need to really think about our work programme and maybe see, and maybe if Dan, you could put something on the agenda of the steering group later in the autumn, and then we can, convene again or decide what we want to do with it, because we don't want to lose this. And as I said, it's like a stepping stone towards, looking at how we work together and how we can work better. So, without further ado, I'm going to tell you that the next meeting of the Health and Wellbeing Board is on the 28th of September 2023 at 2 p.m. And thank you very much for attending.
Thank you.